A very good morning to one and all who have registered to this gLocal Solution Room, Gujarat, India. Myself, Dr. Rashmi Venkatesh, on behalf of EBES Core Committee Sumandeep Vidyapeeth, welcome you all to today's gLocal Solution Room. Sumandeep Vidyapeeth is the first medical deemed to be university in state of Gujarat, and it is well known for providing quality education and has always provided the best platform for various scientific activities. Sumandeep Vidyapeeth gives platform for advanced learning process to enhance our evidence-based practice skills. Today, in this gLocal Solution Room, we will be discussing about the preventive measures to reduce the medication errors. Today, we have 5 well-known speakers with us. Dr. Bikas Mevi, he is Professor Pharmacology, Postgraduate Institute of Medical Education and Research, Chandigarh. Professor Suresh K. Sharma, Professor and Principal, College of Nursing, AIMS, Jodhpur. Dr. Aditya K. Agarwal, Associate Professor, Department of Orthopedics, Sumandeep Vidyapeeth. Dr. Jayant Patarkar, Assistant Professor, Department of Pharmacology, Sumandeep Vidyapeeth, and Dr. Sarvajit Kare, he is Assistant Professor, Department of Pharmacy, Sumandeep Vidyapeeth. And the scientific sessions will be moderated by Dr. Seema Bargale. She is Professor, Pediatric and Preventive Dentistry, KM Shah Dental College, Sumandeep Vidyapeeth. Now I request our Honorable Vice Chancellor, Sir, Dr. Rajesh Barani, to deliver a welcome address. Over to you, sir.
Thank you, Rashmi. A very good morning to all. I bring you greetings from Sumandeep Vidyapeeth, which is a deemed to be university. And as Rashmi pointed out, this is a pioneer institution which has introduced a novel healthcare education system named as the evidence-based education system for the first time in the country. The changing needs of the stakeholders in healthcare sector globally can be achieved only by following evidence-based practice. That is the need that we all are very much aware of. Every student at our institution is prepared for evidence-based practice through the system of EBES. And I'm glad to say that our core committee members are responsible and have very effectively implemented and carried out the execution of this process. I feel we are fortunate enough to have been selected for participating in the JBI gLocal Solution Rooms, which I understand is a series of dynamic and interactive, locally held events in various countries and languages, and are held to find solutions for the challenges health professionals face in implementing evidence in their clinical settings. I understand we are one of the 4 participants from India. This program had started from the 6th of June. This week-long program will continue till the 12th of June. I had gone through the website and I found quite a few interesting topics which are being covered in this session, right from getting evidence, implementing evidence in clinical practice, bridging the gap between evidence and practice, to just name a few. Sumandeep Vidyapeeth Center for Evidence-Based Healthcare has today created JBI gLocal Solution Room for discussing a very interesting topic, an evidence-based approach to reduce medication errors in developing nations. Our team realized that due to various reasons like self-medication, over-the-counter drug availability, errors in primary care prescription, all lead to a large number of medication errors in our country especially. Due to these undesirable outcomes occur, which include adverse drug reaction, drug-to-drug interactions, lack of efficacy, suboptimal patient adherence, and poor quality life in patient experience. But the data pertaining to this is relatively scarce. In today's JBI gLocal Solution Room, I am so confident we will be able to discuss various factors associated with medication errors at every level and the possible evidence-based approach to not only identify, prevent, but also to monitor these medication errors. I welcome the keynote speakers, Dr. Vikas Mehdi from Chandigarh, Dr. Suresh Sharma from Jodhpur, and our own faculty, Dr. Jayant Patharkar, Dr. Aditya Agarwal, and Dr. Sarvajit Khare. A warm welcome to you all to having found time to join us in this program. It would not be proper if I did not compliment the organizing committee, ably led by Dr. Rashmi Venkatesh, the organizing chairman, the organizing secretary, Dr. Nirali Chauhan, and Dr. Seema Bargale, moderator, for all having put in a tremendous effort in organizing this seminar. So, on behalf of Sumandip Vidyapith, I welcome you all to this gLocal Solution Room. I wish this event a great success. Thank you so much.
Thank you, sir. Now I request Dr. Seema Bargale to initiate the scientific session.
Good morning, one and all. Today's first speaker is Dr. Vikas Mehdi. He is a professor from the Department of Pharmacology from Chandigarh, and he's also editor-in-chief in Indian Journal of Pharmacology. He is additional medical superintendent for Founder Experimental Pharmacology and Neurobehavioral Laboratory. He's also a coordinator in PGI-MER as a Pharmacovigilance and Metrovigilance Center, Regional Coordinator in North Zone, Ministry of Youth and Sports, Government of India, Co-Convener India Initiate Program. He has got numerous awards like Dr. D.N. Prasad Memorial Award with Gold Medal from New Delhi, Dr. V.K. Bhargava Award with Gold Medal, and Dr. B.N. Ghosh and Colonel Ramnath Chopra Oration from IPS. So he has been dedicated 2% of his scientific across the world conducted by elsewhere in Stanford University. He has been having 5 books as publication and almost more than 500 research papers. So we welcome you, Vikas Mehdi, sir. Over to you, sir.
Thank you, ma'am. Thank you, sir. Can you allow me to upload the slide? You have to make it a stop presentation.
Yes, sir. I have done the stop share. Just check it out.
Can you see the slide? Can you hear me? Can you see the slide, ma'am?
Yes, Dr. Mehdi.
Yes,
it can be seen and we can hear you also.
And the slide is also changing, no?
Yes,
slide
sir.
is also.
Yes, sir. Yes, sir.
Thank you very much. Actually, Your university have been twice, and before COVID also I was there. I remember with Dr. Kameshwar Prasad, both of us, and we'd like to also conduct some of the program, skill development program at university. We'll talk to you later. Now I congratulate you for keeping this very important topic, which is not addressed in a hospital. That is medication error and the patient safety, and what are the factors that exactly influence the medication error. So this is very important topic we must discuss. Now, as a doctors, if we say, what does it mean that you say, usually we ask the student or the doctors, do you understand that if we talk about what is the meaning of patient safety? And this need to be asked, like, did you ask at any time, are you safe in a hospital? And I have been doing several programs when I ask the student that, have you asked at any time, are you safe in a hospital when the patient they come in the OPD or they are admitted in a hospital? I think this is the time has come that we must think that how they're safe. Like we always say, I'll give you an example of aviation industry. So they have a very stringent SOP. Now, if you say when you go to OPD, indoor, or you go to ICU, what are the stringent SOP we follow in order to prevent any consequences? That means the medication error lead to consequences like adverse event. I think time has come that we must think, and that is why if you look at that, these are new discipline has been emphasized that we need to collect a report, we need to analyze, and we need to take a step that how you are going to prevent the medication error that has come. Now, if I take an example of US, they use a system called COP system. I'll describe in detail how the COP system is implemented in a hospital. Now, after implementing the COP system, they are losing around 110,000 patients because of medication error. Similarly, another countries like UK, if you take an example, they also have a similar system. They lose around 44,000 patients in a year. So you can imagine that we don't have a system, we do not have a record, we do not report if we come across any medication error. We wanted to hide this. So you can imagine how many under-reporting is there, and because of that, how many ADR are we are having in a hospital. So you can think about that. So that is why WHO is saying that this is a endemic situation. And that is why you have to really think that we, during the COVID time, we say that healthcare worker safety, we discuss. As you can see, that every September, we celebrate a pharmacovigilance or patient safety during the work. So there also it has been included healthcare worker safety. So this is also become an endemic situation as per the WHO, we must think of that. Now, coming to the reason is why there is an error take place. Now, if you say that if I work for 16 to 17 hours, and that is usually the resident, they are posted there, and it is likely to cause a human error. And second thing is that in our setup, we do not have a streamline, like patient goes to PhD, they go to several general practitioner. By the time they actually come to the tertiary care centers, it is already having a very, particular, like diabetes, if you talk about, by the time they come to the tertiary care center, they already have a metabolic syndrome with, comorbid condition. As we do not have a uniform policy for tackling, like how we tackle in government hospital, how we do it in a private hospital. So that is why there is likely to be a system failure. And that is why the government has actually that need to take that, can you take a model? Like if you describe, like if you look at this model, that how you can have an organization, because you need a skilled manpower, and you need to identify what are the contributory factors that influence that it can lead to medication error, or it can lead to effective clinical practice. So that is why you need to have some kind of a defense mechanism so that you can identify medication error and immediately you can take a step that how you're going to prevent the medication error, or so that you can minimize any of the accident. And if you look at this model, we can take in an Indian situation that how we are going to do it. Like suppose you go to a clinical specialty medicine, how we are going to develop a SOP, or you go to the surgery, how we are going to developing a SOP, like in pre-operative. during the operation or post-operative, similarly, any of the super specialty division. So that can be implemented looking at Indian context, and it can be look at that how you're going to validate and how you can train the manpower so that you can identify a report and you can have your own database that what are the common cause it can cause error and how to prevent this. And that is why we need to do it. And looking at this, and that is a reason, as you can say, that the government has started several safety programs in the institute. And these are the safety program. If you see that 2010, what we launched is PBPI program. Under this program, we have a pharmacovigilance program of India. In 2010, it was started. Then 2011, November, again, it was started with a humovigilance program. Any ADR or any error which lead to ADR because of the blood product or because of blood transfusion. And in 2015, you could see that another program was started by government, that is by Metro Vigilance program, because we use a lot of materials. We do not know how many materials are there. Some of the materials product, it is notified. Till today, we have 37 notified products. But if you look at that, more than 1,000 products are there. We're not able to regulate or notify it. So it also includes the devices, that is class 1, class 2, class 3, class 4 devices, and also include the diagnostic and other aspects. So government started because of incident happened in somewhere in Kolkata and Patiala, where the baby was born in an incubator. So they started. You must remember that patient were put into the MRI with oxygen cylinder. It was sucked and patient died. So these are the program Metro Vigilance in 2015 started. Then if you look at that, other biologics or biosimilar, it has been flooded with the market since 2014. So there is a plan to start a biovigilance program. Then we have a program of harbour-vigilance, because when you look at any prescription, if you do a prescription audit, if you see that, WHO say that all these minimal criteria should be there. How many, drug has been prescribed, how many are fixed dose combination, how many are within the essential list, is there any injectable antibiotic, like that you analyze. So if you look at that, you need to start that before you check any of the prescription, when they come from a village, they have already treated with some Ayurvedic preparation or botanical product. So we do not get to know, the allopathic physician do not get to know that is there any chances of drug-drug interaction, drug-herb interaction, or any of the food product also never counted it. So that is what, that plan to start a harbour-vigilance program, it is already in infancy. And then another thing is that we have a problem with antimicrobial resistance. Or many of the drug, if you see that even if we have a product, a standard drug to use, but it is refractory. So that is why that another program is antimicrobial. So altogether, if you see that under this PBPA umbrella, pharmacovigilance program of India, then metro vigilance, humovigilance, harbour-vigilance, biovigilance, and antimicrobial. So these programs have been implemented almost all these, medical colleges. As you can see that we have 605 medical colleges, 1,400, different university. Then we have 22 aims. So if you can plan to implement all, because we have a largest network right now, we have more than 567 centers are there. So that's how we can regulate, or you can streamline, and we can have a rational therapy by doing this. And from ICMR also, it has been started the rational use of drug centers. So they also come up with a prescription software where you can enter, you can analyze a prescription. So this need to be implemented in all the medical colleges, and all this pharmacy and like especially PharmD or pharmacology department, they can coordinate with the clinician. Then these are the program has been implemented. And in order to combat this, that you have to think of how you're going to tackling the intern, get new doctors, Indian medical graduates. So ICMR has come up with a program for prescription skill development program. So since your Vice Chancellor is here, I'd like to highlight that this program was started during the COVID. So basic purpose of this program is that all the we have developed 3 modules, and under this 43 and they can take the classes online, and they can take kind of a UK model. So they are not allowed to write a prescription if they are not developed the skill. So once they take the exam, that if they score 70%, they are likely to take it, they are allowed to take this, they will be allowing to do the prescription. Now, one thing is that if there is a error take place, so everybody blame to the doctors, nurses, pharmacists, nobody take this. So this is very important that when we talk about patient care services, we should have a better communication among provider. Like doctors should speak to the nurses, nurses with the pharmacists. There should be good coordination, and that is why you keep all the data. So if you look at that, how the data are kept in order to have a retrospective analysis, like OPD data, we keep it for 5 years at least. Indoor data, we kept it for 10 years. Or medical legal, you know that it is going to continue for, you do not know how long you have to keep it. But we have a concept of digitalized under the government has also started digitalized that at least electronic health record. So if we take an example of some of these countries where they keep all the data onto electronic health record, like you can take an example of Estonia. Every citizen has a data on electronic. So we have a provision that we are trying to make it digitalized, but only thing is that we need to put it that there should be uniform policy to keep the data. So if you say throughout India, there should be policy that you are going to keep it for 5 years, or indoor data 10 years, or medical legal, you have to keep it for long. You can take an example of some of the country like Australia, they keep the data for 25 years. Why 25 years? If you ask, they said that if you want today, by you become 18, you came to know something wrong with the delivery, you can go to legal court of law. So idea is keeping the data for 25 years. So here that uniform policy, like even if you do a preclinical data, we keep it for 9 years, 3 cycle. Clinical research, we keep it for 5 years. So this, even medical hospital data also we should keep it. And as you can see that we have an institute, APEC Institute, and we never destroy any data. So that is the policy need to be taken. Now I was trying to convey that it's not only doctors, everybody is responsible, whether you talk about nurses, office staff, physiotherapists, anybody. So there should be good coordination. You should have a strong archival procedure for medical record department, and that should be there. So this is what, as you can see that in the dry record, we talk about weight record, we talk about electronic records. So we are going into the electronic health record. That is what we have to do. And there should be coordination among them. Now, another important point is when you think about delivery, healthcare delivery, we never, like you take an example of government hospital, did you discuss at any time, like I asked the question on the first slide, did you ask the patient, are you safe in a hospital? Second thing is, if you ask that, what about quality of delivery? You know that we have a several hospital which is accredited hospital, because they actually quantify that it is, if it is accredited, you have a policy for person center, then all the safety program is implemented and all it is effective. So we need to think of a quality also. But sometimes if you see that, if you talk about quality also, then you may be having a 7-star facilities. But it is very important to train doctor, nurses, and pharmacists that whenever somebody falls sick, that emotional angle is very important. For example, if you fall sick, if somebody come and tell you, how are you? Do you need anything? It's actually give a moral boost. So that is why it's not only instrument or sophisticated instrument or all the SOP, that emotional angle, how you exactly handle, how you exactly manage the patient, and how do you communicate with polite language. This is also going to give the boost. And this is a model, everybody, like, that somebody had, I remember one of the surgeon in PGI, one lady, every day she comes and the doctor say, how are you? Yeah, are you fine? And it gives a moral boost. So that should be there, that we need to train our junior also, that it's not only importance of sophisticated instrument or healthcare, but this is also very important to emotional language. Now, how do you improve? Like I have been looking after some of the center for almost 9 years. I know each and every part of this hospital. But if you can take a patient experience, like for example, patient come to the OPD, and after making an OPD card, it goes to general medicine, then it is referred to super specialty. How difficult to reach to the consultant? How difficult to reach for paying a counter fees? How difficult to reach for going for an investigation? This all input you need to take. If it is illiterate patient, if it is a educated patient, can they look at the synergies, or did you keep any of this information people? How many questions it comes? What are the questions? Based on that, you are going to improve, and which will be safe and effective method, and in order to keep the quality of patient care. And that should be there. I think it is a dynamic process, continuous process. Every year you should make an assessment in the hospital so that you can improve the healthcare delivery system. Now, as you can see that patient safety is a new healthcare discipline I describe as it is an endemic situation. Now, how do you define the medication error? Because it is exactly preventable. Only thing is sometimes it has happened that you as a consultant look at 100 patients. So you do not have a contact time. So within 100, like maybe within 5 minutes, you are going to take a history, you examine, you ask for the investigation, make a provisional diagnosis, start with a drug therapy. As you can say that I had worked in UK where we get around 3 to 5 patients. So what we do is 1 hour or 1.5 hours, we spend everything in detail about the disease, what medicine to be taken, how medicine should be judiciously taken. Then we also, with educational process, we improve the compliance of the patient. And if any problem it comes, then you contact us. So that is why, because since there is a communication gap, we do not have a contact time. So this become, though it is preventable, but we never get to know that patient is having the problem and they do not know, it is not educated. So that is why even if you talk to patient or in a chronic disease like Alzheimer's, we have to educate the consumers, okay, or caregivers. Now, when you take a definition of, medication error, if you look at the definition of United States National Coordinated Counseling Medication Error Reporting System, they say it is prevention, it is defined. So they say any preventable event that may lead to inappropriate medication use or a patient while medication is in a control or healthcare professional. So basically, if you see that, they look at every aspect of prescription order communication, product labeling, how it is packaging, nomenclature, compounding, dispensing, distribution, administration, education, and monitoring to use. Every step they look at. So that is why they say that every step we need to have a skilled manpower so that you can prevent it. Even the patient should be educated that if they come across any problem, can you prevent the further damage to the patient? And that is what we do. So when you look at the medication error, that can happen at any times. Like we say, you are driving a car, it was about to have an accident, but somehow it is safe. Similarly, we have a reporting system, A, B, C, D. I'll talk about detail. So if it is not reaching to the patient, you can say that according to that. But sometimes because of error, there could be date also. So if you say that when you give a prescription, okay, or you are transcribing, monitoring, administration, every step while dispensing, that we have to be very, very common, like very, very vigilant, so that most common order prescription stays, so that you can prevent and people can have an education so that it can be prevented. Now, one more point I would like to highlight is, it's not question of that medicine causing a harm. Now, if you take an example of these two picture, it has been given a chemotherapeutic agent. Now, are you going to blame the chemotherapeutic agent that it is causing the damage? The answer is no. The reason behind person who is putting the chemotherapeutic agent, they did not have a skill to put the cannula into the vein. And because of that, so it's not every time you have an error that is lead to the ADR, we need to have a skilled manpower also. Suppose I take an example of, one of these things that, did you get a time to ask when you prescribe a medicine that do you have an allergy? And even they do not understand that you ask that do you have a food allergy or any kind of allergy? And that is what we can prevent so many ADRs if you ask a simple question. So even if you do not have a time, just make it a point that you ask about, do you have an allergy? Any problem is there? Any food allergy? So it is going to prevent a lot of consequences. So by the time you must understand that, it's not question of that any error and that lead to ADR. It's not a question, it's the responsibility of physician. It all the teamwork, pharmacists, nurses, caregivers, everybody should be educated. Of course, now the patient become having a Google knowledge. That is also very important to give a balanced information, because sometimes they have a hypothetical one ADR in 10,000 patients. They might be thinking that I have this problem, but it is not so. So that is why we term that medication error. Of course, it is preventable, and you need to take necessary step to how we are going to prevent it. Now, though we do not have much data, Of course, as I said, that we have around 20 center of RUMC center, where exactly what you are doing it in terms of prescription behavior. As you can say that India had taken step from ICMR that unless we train the Indian medical graduate about prescription, and that is why this prescription skill development program has been started. So I request all the intern to join this program so that you become like, how do you prescribe for elderly? How do you prescribe for in a pregnancy or lactating woman? So they wanted to make it that all these prescriptions should be at the same time, that uniform prescription should be there pan India along with standard treatment guideline. As you can see that all the standard treatment guidelines have been released by DHR. So these are some of the data that how many medication error, how frequent it is. It is almost like when you go to medicine, when you go to surgery or in the ICU. So then definitely it will be more. So at least 1 in every 5 doses, you are going to make some mistake. So, and it is going to cost huge amount of money. So that is why it is very important to look at that. Is it going to have an implementation in pharmacotherapeutics outcome, or in terms of mortality and morbidity, legal consequences, and significant problem for health, care. So it should be counted. So that's how we look at. Now, when you compare the healthcare delivery system and just compare, every day we take a flight. Now just think of how they take a stringent action. You might be remember somebody was singing during the Holi in the flight, and air hostess, they were dancing. Next day, all of them were grounded. And that is why last year, that same flight, they had a ground flight and they were dancing. So this is what very important, that if you take a history, aviation history, that how many error take place, maybe 2 error per flight. Or what is a fatal consequence? You can remember one of this Malaysian flight was disappeared. Then recently China, they had an accident. So it is almost 3 fatal accidents per 1 lakh flight hour annually. But if you come to the hospital, if you say that how many people died, like I had given an example of US, where 110,000 patients after implementing POP, UK, they have more than 44,000 patients, they died after implementing POP. Then you go to that, what is the problem? Regarding a drug administration, at least 1 in 5, or there are 7,000 annually died. Okay, or you go to anesthesia, how many error take place, like 2,000 to 10,000. So in case of a surgery, in case of a ICU, it is more 2 error per day. And what happened in emergency medicine? Many times we remember that one of the patients, they had a bronchial asthma, where the terifalin is given in a drip, but it was given directly because of language barrier. So that is why you need to be very, very careful. Like as you say, when you drive a car, stop, look, go. So similar principles should be applied, and any mistake we do, we must discuss, and in order to prevent the further mistake that should be there. So impact of medication error is very, very high because it is not reported. Nobody knows this, and mortality, though we know it is preventable. And if you get a case in a hospital, like you have been working for last 50 years, one case can have a devastation for physician and to the hospital reputation also. Then there are a lot of costs involved for reputation of facilities, or there could be penalty or legal consequences. So that is why you need to look at step that how to prevent, how to create an awareness about the medication error among the team and among the consumers, among the patient. So basically you need to see that how you're going to handle it. You happen to go to any of the South hospital, they have a very good system of medication management. Okay, we are not addressing any of the issue like storage, like in Baroda, Mr. PD Seth is there, who had actually written the storage condition, and it was supposed to be implemented in all the hospital. So you happen to go to any hospital, how you're giving a storage. Okay, are you keeping a logbook, calibration? Everything should be maintained. So then you talk about administration of dispensing of the drug. What is your SOP, standard operating procedure? And did you have a training after making a SOP? These are things should be there. Now, as you can see that in developed countries, they have a system of reporting. So if you look at this pie diagram, looking at the color, so there is an error, but there is no harm. So you can look at the color, A type of category, there is no error. Or if you say little bluish color, that error, but there is no harm. That means there is an error in place, but it did not go to the patient. But when you say that harm is occurred or error lead to date, so you can say by definition A category, B category, C, D, E, F, G, H, and if you find an I category, that means you get to know that because of the error, patient is no more. So that is why we need to think about that. What is the consequence of error and how that error lead to these consequences? So if you say that incorrect state, you do not know how long you need to continue. You do not have an accurate dose for a patient. So dose is not accurate, and that is why that you need to train that how you suppose in a special population like for pediatrics or geriatric population. So this, are you going to use an expired product? Okay, so incorrect preparation. These are should be looking at while going the dispensing. It's not only doctor, pharmacists and nurses should be very, very trained, and so that they can take a appropriate. Now, how many errors are there? As you can say that earlier when you read a prescription and nobody can read the prescription, you used to think that he's a very big doctor. Now we could understand that everybody said whatever you write, you have to write in generic name. Whatever you write in capital. So that means that there should not be any miscommunication because of prescription. So there is a prescription error, or there is a because of handwriting or not releasable. So there is a dispensing error. There could be administrative monitoring error, potential error, or there is a problem with compliance error, clerical error. There are so many errors. But in order to prevent this prescription error, what you say that, as we say that we started a program, prescription skill development program. So that need to be looking at uniformity in terms of standard treatment guideline, which is released by DHR. Now coming to this number of prescription error, as you can say that we do not have a contact time. There is a insufficient, inadequate information to the patient. And whatever language you speak also, if you speak in English also, patient will not say no, they will say yes, yes, yes. Later on, they will say that, kya bola mujhe samajh mein nahi aaya. So there is a lack of knowledge about the drug therapy. Like I talked about balance information. Maybe they can go for a Google, but they need to have a Google, balance information. So we need to work on, communication, how you can, improve. As you can say that we have a tele-prescription, or there is a software for using the prescription also. So whatever confusion, misleading drug label or packaging, it should be, clarified. So then we work on a poor drug storage. We never look at that, how the drug is stored. Even at home also, how it is neglected. You're keeping in a corner, in a dark place. We never think of that. Is it, photosensitive, or it is sensitive to the temperature? We never think of that. So this need to be looked at, and never accept any verbal communication. Okay. So because I remember in AIMS casualty, we used to ask, call urology. Then you find the neurology people come. So then we used to say, call urology, U for umbrella, N for Netherlands, something like that, in order to prevent, mistake. So these are some examples that, how many, that if you look at the prescription, of course, India has started with ICMR guidance, that number of prescription, how many overdose, like I said, that you can just think of, WHO criteria. WHO criteria means you say that number of prescription, number of drugs have been prescribed, how many are FDCs, how many are, we need an essential list, how many are injectable, how many are antibiotic. You can make an, or among that, is there any overdose, underdose, any missing information, like that you can go. So there is a system of that you can implement. One of this implementation is that is COP system, what I refer a couple of times, computer physician entry system. Then you can have a barcode system or scanner, or you have a national drug code, system or automated. So there are several systems, but most sophisticated one is COP system. So I'm going to discuss about COP system. So in COP system, what you do, that doctor write the prescription for a particular patient. Now, if you see that it comes to the nurse's terminal, and nurses will verify from the computer that what are the drug has been prescribed. So all the spelling mistake, dosage, duration, everything is verified. What is a route of administration, and this verification is done within hospital formulary. So these are the hospital formulary. As a doctors, how many of you have read the hospital formulary, and is it updated regularly? That need to be looked at in Indian setup. So once it is done, as you can say that when the patient get admitted, all the medicine will be kept in a particular box. So nurses will go and take out the medicine, and from there, she will carry And as you can say that before she administered, they confirm is it that patient doctor has prescribed. So every patient have a barcode, scanner. So they scan it, then only they administer that medicine. So that's how they do it. And after implementing this program also, still they lose 110,000 patients. So you can imagine in other developing situation that how many patients we lose, we do not know. Then another system is barcoding system. It is also very popular and it is affordable. So with this also we can implement in a hospital. So as per the recommendation of US FDA, Drug Administration. So here you can see that these are the recommendations that, you need to look at the quality of medicine also. Then everything you look. So when you check the quality of medicine, you can say that, are you going to check batch number, license number, everything you check. So when you procure in a hospital, as you can say that all we ask for a bioequivalence certificate, we randomly send the samples for a quality assessment, everything it is done. So that's how we do it. So some of the recommendation to prevent medication error, that if you can develop an SOP, like we talk about the model. So same model, can you have a defense barrier so that you can, looking at Indian setup, that you can establish and maintain a functional formulary with adequate number of well-trained person, and you should have a suitable work environment which is safe, effective for drug preparation, and you have a defined system for quality improvement maintained. So basically, if you say you develop a software or you implement a software, exactly how you are going to do it. Basic purpose is if you work on any hospital formulary, you need to ask that, do you have a formulary as a clinician or as a doctors? Okay, how frequently this formulary is updated? Are you looking at, so that we are also familiar with the standard treatment guideline for all the diseases. So if you train the prescriber, like we had a program for an intern. So initially you train about all the models, like 47 models. And we train them how you give a prescription, how do you justify, okay, how to prescribe in generic form. Okay, so everything, do not accept any verbal orders. So these are things should be there. And the pharmacists need to be trained because we have a clinical pharmacist. Okay, so they exactly know that how to dispense. And during the dispensing, if they educate the patient, so that patient become familiar, they know, because when you talk to a chronic patient, they are having Alzheimer's, or you talk to the caregivers or any of the hypertension, diabetes, so they become familiar with all that travel. So they exactly know that if there is an ADR, whom to contact, how to contact, okay, how to take an appropriate step. So that is why. Same time, if you look at nurses are inpatient, they're all the time in the ward. So if you can train the nurses about that, how that they should create an awareness about medication error and how to prevent it, and can they develop a SOP so that step by step, if the new person join, they should be trained how to prevent an particular error. So I think that this would be a great step if you do the train nurses and accordingly. Now coming to the patient and family, I said that now with the Google term, everybody knows about disease and drug therapy. Only thing we need to tell, addressing their question with a balanced information. If you read diclofenac sodium causes hepatotoxicity, so they'll think that if they take diclofenac sodium, liver is going to fail. You should tell them if you take 50 milligram thrice a day, maybe 1.5% will have a hepatotoxicity, and it is reversible. If you ask them that, how do you keep a medicine? Where do you keep it? Do you have a patient diary? A lot of people, they keep the medicine in the bathroom. And when they take at night, they don't switch on the light also. We just tell them simple language that, can you switch on the light? Just check what medicine you have taken. Okay, so accordingly. So about the storage condition, and if it is expired also, how we are going to dispose it. As you can say that we have the issue of eco. Okay, it is affecting contamination, soil, waters. You hardly see a vulture. So these are the examples that if you need to train that how do you dispose, how do you take, how do you storage, and educate the patient and family, that is a great job. So you can avoid the medication error at home by educate the patient and the family. And this will be a great step that all the stakeholders are educated, and they'll have a skill with doctor, nurses, pharmacists, along with the patient. So that is why that reporting system some of the developed country has started. Of course, we do not have a reporting system. We have a ADR reporting system. We need to incorporate that medication error lead to ADR. We have to have a reporting system. So unless you have a database, how many error it is leading to the event, adverse event, that need to look at, and then only you can go for a data mining. So here if you see that some of the reporting system that where they give a detailed, factual and objective manner, and with this, they also identify the factor that continue with the error. So that is why you can see that, and we need to also address the legality or reducing. Of course, you can say that these are the reporting system, these are confidential, or you can go to only database, it is not going to disclose. So one of the example of reporting system, what we say, A category, B category, C, D, E, F, or I, which you get to know that because of the drug, patient died. So this is what the reporting system is there. We can implement the same system here. And along with this, if you look at the databases across the world, we have a FDA MedWatch, or there is an Institute of Safe Medicine Practice, or MedMax. So these are the database. Globally, it is report. So we have a regulation from US FDA also, how to avoid the error, or how to keep all the databases. So that is also there. So we need to start. So I just wanted to conclude this, that I congratulate that you started that. I also like, we celebrated on 5th May Smart Medication Day. We are going to celebrate again in September patient safety, okay, healthcare safety with pharmacovigilance. So this is all together. If you look at it, all 7 days, we are going to create an awareness. Similarly, if we can do this and create an awareness that there is a problem with medication error and it is underlying or under-reporting. So not only that you can blame to the doctors or the pharmacists and nurses, everybody is responsible. We need to create awareness among ourselves. If we do a mistake, can we discuss among ourselves so that we can prevent, or you can develop our SOP to prevent a further mistake, so that we can, as you can understand by this presentation, that medication error basically is preventable. So only you need to know that how to identify, can you implement a model for identifying with a defense barrier so that you can prevent it. I think this, education or creating awareness should continue. Thank you very much.
Very well said, sir. It is really good exposure we have got about the medical errors, and it was new to us to know about the medical errors also. There are a few questions, sir, I want to give you. One is, what is the role of clinical pharmacist in the patient's prescription, whatever you are going to give, sir? So
yeah, if you look at a Western model, whenever they go for a round, they are also included clinical pharmacologist along with a team, along with a physician. So basic purpose is there. Are they following what about the prescription, and is it as per WHO criteria, then as per standard treatment guideline? Okay, regarding appropriate dose, everything is verified. These are the role are there. I think you need to start. Some of the hospital they already started looking at, as you can say that we have an e-prescription now. Okay, some of these metros or super specialty hospital, they have an e-prescription. So in e-prescription, everything is come with the capital letters. Okay, so exactly the dose, duration, how long it will continue, what are the precautions need to be taken, everything given in detail, and it is verified in different states. And that if you implement that, definitely it will be useful. Okay, you can get rid of a lot of problems. Yeah. Thank you.
Okay, sir. As you said, it is e-prescription. Any softwares or like that are there so that we can give the e-prescription for all the medical professionals?
Yeah, I had described about POP system. This is also kind of software that doctor write with a handwriting. Like in a tab, you can write. So from the tab, it goes to the nurse's terminal where it is verified from the hospital formula. What are the drug is available? What are the doses is available? Is it that they write that the name is accurately written? So everything is verified. So there are different softwares are available, but whenever you look for the software, then you can say that is it validated. Now, second thing is in Indian context, because outside there is no fixed dose combination. For example, how it is different from Western countries or India, outside there is no fixed dose combination. But here there is a huge number of fixed dose combination. So then you have to look at that, is this software also address the fixed dose combination? Okay, so like that you have to also see. Thank you.
Okay, so thank you. There is one more question, like in India, how we can apply, sir, this medical error, as you said, we are supposed to use it. So how we can work together for this medical errors to apply? As you said, it is globally outside, it has been done. So any suggestions or something like that?
I think we can do it from the PBPI program, because we have already pharmacovigilance, metrovigilance, hemovigilance program is there. So we can incorporate this part also. We can have a medication error, program along with PBPI program. And I think this is a high time we need to implement it. Yeah.
Because I think so it is an hour, actually it's need of an hour.
Yes,
so
yes.
that is the thing.
Okay.
And actually one more suggestion has been given by Chiplunkar. It says compulsory deposition of expired and unused medicine in a special expiry boxes at the pharmacy should be implemented. So it will save soil and environment. What is your note on this?
I have already taken an initiative. If you read some of my paper, which address the eco-pharmacovigilance. So I have given a couple of examples, like those who are elderly people, they remember vulture. And now younger population will hardly see a vulture. So government has started a park, vulture park near Chandigarh, Pinjore area. So all you is, you just take an example, diclofenac was used in a cow, for injectable. So when these flushes take that vulture, they develop a acute renal failure. So there are several examples along with that. It is contaminated with water, antibiotic resistance. So I think we need to develop a policy. We have actually submitted a project to look at the real picture in the environmental contamination, water contamination, how it is going to affect, because though in a hospital we have a biomedical waste disposable, but how expiry medicine is going to dispose, okay, that need to be looked at. And I think you should take a policy on it. Thank you.
Okay. Thank you very much, sir, for your nice answers which have been given by us. So,
because time constant, I wanted to take it for more than 1 hour, but because of time, I was meeting. So
it was quite useful, sir, to us to know about the medical errors also. Okay. So thank you very much, sir, from all the Sumandip Parivar. Thank you very much.
Thank you. So I just leave the meeting. So
okay.
Thank you. Thank you.
You can stop the sharing.
Yeah, I'll do.
Okay, so good afternoon all. Now Dr. Aditya K. Agarwal, he's completed his graduation from Kamarsad Medical College and in India in 2011. He worked as and completed his MCH from University of Dundee in 2015. He is having a clinical fellowship in hand and microvascular surgery from Singapore General Hospital. He has also got a clinical fellowship and also knee, shoulder and knee orthoplasty and sports medicine from Singapore General Hospital, which also he has got 10 years of academic experience and working experience with the fixation of open and closed complex upper and lower extremity surgeries and arthroscopic reconstruction of knee and shoulder joint. He has almost published 30 and more publications in national and international journals. He has achieved Dr. D.P. Bakshi gold medal for his best paper presentation at Jaipur conference in 2016. He has also received the gold medal from research under literal access from the World Academic Council, January 2020. So he is also invited as the international faculty at World Congress Orthopedics, Milan in the year July 2018, and also as a pre-basic course webinar in September 2021. He is also an active member of Indian Medical Association, Indian Orthopedic Association, or also in International Cartilage Repair Society, International Society of Orthoscopy of Knee and Orthopedic Surgery, and he's also reviewer in many of the reputed journals. So over to Aditya sir, who is going to brief us about the EBS gLocal solution media. You're welcome, sir.
Thank you, madam. Okay, so in this presentation, I would like to introduce about what is the JBI. So JBI is being basically executive director is Professor Joe Jordan, and it helps to connect you to achieve our vision and mission, which helps us to provide better evidence for better outcomes. And like our logo suggests, it creates a ripple effect of change in healthcare globally. So JBI is concerned with improving the healthcare outcomes of the communities globally by promoting and supporting the use of best available evidence to inform decisions made at the point of care. And this is also available to inform the decisions. And the work begins and ends with the needs of those working in and using healthcare services. It also responds. It also seeks to respond to their questions and provide high quality, reliable information that is pragmatic and useful where it counts. So what is JBI? It's a leading global evidence-based healthcare organization. It includes evidence, education, software, and research. It's an international research organization that develops and delivers unique evidence-based information, education, and training, which is designed to improve healthcare practice and healthcare outcomes. To achieve this, JBI works with universities and hospitals from across the globe through the JBI collaboration. And in doing so, JBI ensures the research evidence it seeks to synthesize, transfer, and implement in culturally inclusive and relevant across the diversity of healthcare internationally. So the vision of JBI is to provide better evidence to achieve better outcomes and brighter
We are very sorry for technical issues. Dr. Aditya Agarwal, he'll be speaking with us now. Over to you, sir.
So in this presentation, I would like to introduce about JBI, its model on evidence-based healthcare, the origin and purpose of JBI gLocal Solution Room. So JBI, the professor Joe Jordan is the executive director. JBI helps to connect you, and it helps to achieve our vision and mission to provide better evidence for better outcomes. And like our logo of JBI, it suggests to create a ripple effect of change in healthcare globally. JBI is concerned with improving health outcomes in communities globally by promoting and supporting the use of best available evidence to inform decisions made at the point of care. This work begins and ends with the needs of those working in and using healthcare services. JBI seeks to respond to their questions and provide high quality, reliable information that is pragmatic and useful where it counts. So what is JBI? It's a leading global evidence-based healthcare organization. It includes evidence, education, software, and research. And it is working across more than 40 countries in partnership with experts across the world to improve the health outcomes. It's an international research organization that develops and delivers unique evidence-based information, software, education, and training designed to improve healthcare practice and health outcomes. To achieve this, JBI works with universities and hospitals from across the globe through JBI collaboration. And thus it ensures that the research evidence it seeks to synthesize, transfer, and implement is culturally inclusive, relevant across the diversity of healthcare internationally. The vision is to provide better evidence for better outcomes and a brighter future. The mission is to promote and support evidence-based healthcare. The headquarters of JBI are in Adelaide, Australia, and we are proud to be an international collaborator. So JBI's approach to healthcare or evidence-based healthcare is unique. It considers evidence-based healthcare as decision-making that considers the feasibility, appropriateness, meaningfulness, and effectiveness. It helps to answer the questions, that is, how big is the problem, why is the problem, how does it make the patients feel better, and what is the impact of that context. The global healthcare needs as identified by clinicians or patients are addressed through the generation of research evidence that is effective, feasible, appropriate, and meaningful to specific population, cultures, and settings. This evidence is collated and the results are appraised, synthesized, and transferred to service delivery settings and health professionals who utilize it and evaluate its impact on health outcomes, health systems, and professional practice. The best available evidence, the context in which the care is delivered, the individual patients, and the professional judgment, as well as the expertise of health professionals, are involved in this process.
Aditya, you're muted.
So there is a gap between research and practice, which has to be bridged. And that is what the mission and vision of JBI is. So evidence-based clinical audit and feedback is recognized as a valuable approach to implementing evidence into practice. What does it include? It includes the 7 steps. Step 1 is to identify the practice area. Step 2 is to engage the change agents. Step 3 is access, context, and readiness for change. Step 4 is to review the practice against evidence-based criteria. Step 5 is to implement the change to practice. Step 6 is reassess the practice. And last step is to plan for sustainability. So it's like a plan, do, study, act cycle with emphasis on clinical leadership and evidence-based practice change. It is firmly grounded in audit, feedback, and re-audit process. And it involves more than 500 healthcare professionals who have successfully implemented and changed practice following this framework in small, large, multi-site studies. The widespread impact of the work of JBI worldwide is attributable to the local and global partnership that ensure that activities are context-driven by individuals and groups that understand their specific healthcare environments. Through its international framework, JBI is well positioned to be a leader in producing, disseminating, and providing a framework for the use of best available research evidence to inform clinical decision-making to improve health outcomes globally. JBI collaboration is the engine that drives the JBI effort worldwide. It collaborates with more than 75 centers of excellence and affiliated groups in all the regions of the world. It is the largest global collaboration to integrate evidence-based healthcare within a theory-informed model. Entities promote and support the use of evidence-based healthcare globally. Each entity leads EBSC initiatives in the region, state, country, and specialty. We are driven by a united desire to contribute to the improvements in the quality and outcomes of healthcare globally through the delivery of high quality programs of evidence synthesis, transfer, and implementation. It includes clinicians and consumers, with each collaborating entity leading specific evidence-based initiatives in the region. So before we begin with further sessions, you should know what is globalization. Globalization is the term which is being popularized by sociologist Ronald Robertson, who traced its roots back in Japanese business, which emphasizes a global outcome adapted to local conditions. So globalization stresses the idea of contemporary globalization, influencing the local level of society and localization of globality. So what does globalization have to do with evidence-based healthcare? The JBI model of evidence-based healthcare recognizes first and foremost the critical relationship between research and practice. The yellow wedge at the top, it speaks of both the globality and locality of evidence-based healthcare. It begins and ends with the needs of health professionals, health services, and health service users. If the researchers and synthesists are not engaged with those working in practice, are not responding to your knowledge needs, we'll never achieve the sustainable improvement or impact where it matters the most. Working in collaboration with each other determines what those questions are, then supporting to implement the answers is the only way we can achieve our vision and mission. So working locally, local knowledge or local based disadvantage hinders the performance of evidence. A powerful crucible where universal knowledge is localized to support improved outcomes across the international borders and cultures. Again, it is only possible with a team without acknowledging or accepting that different cultures and clinical environment present different challenges. And we hope that this event contributes to overcoming some barriers, helps us to understand the challenges, and provides the opportunity to generate the solutions together in partnership. So the idea of the solution room came from a powerful conference session concept designed to engage and connect attendees and also to provide peer-supported advice on pressing issues. Pairing that with real-life challenges related to implementation seemed an obvious choice and a perfect opportunity for JBI. There is learning to be achieved on both sides of the podium. It is an opportunity to share experiences and co-create partnerships for purpose to achieve better health outcomes by applying global knowledge to local challenges. We hope you will enjoy the further sessions today in finding solutions to our JBI challenges. If you are interested further in learning more about JBI or keeping up with the local and global events and news, make sure you remain connected with us via social and digital media platforms. Thank you.
Sorry for inconvenience of due to some technical error. Now we are going to start with the presentation of Dr. Suresh Sharma sir. So today now we are going to start with the session of Dr. Suresh K. Sarma sir. He is a professor. He has completed his BSc Nursing and also MSc Medical Surgical Nursing and PhD in the Department of Public Administration, and he has 4 postdoctoral fellowship to his credit. He has almost 17 years of academic and teaching experience, and presently is serving as a professor and principal at the College of Nursing, AIMS, Jodhpur, Rajasthan. He has been awarded as University First Rank Holder in BSc Nursing program in 2000, and also he has been awarded as a prestigious award, that is Florence Nightingale Award in 2001 by the Florence Nightingale Nurses Welfare Association, Bangalore, Indian and Anglo Unity Center, UK at Bangalore in 2001. He has also got a university medal for standing first in MSc Nursing at National Institute of Nursing, PGI MER in Chandigarh 2005. He had a PhD Pharma scholarship received during the pursuing PhD program in Punjab University in 2019. He has got even the Best Teacher Award by the AIMS Rishikesh in 2018. He is a fellow ICN Leadership Program, Global Nursing Leadership Institute, Geneva, Switzerland 2020. He has got various publications for his, that is, he has textbook authored, almost 11 chapters he has been authored in 45 original review and research papers has been published. He has got even the book reviewed, 4 book reviews has been done, and also the funded research project. He has extramural research project 7 and intramural RT 35. He has got national level assignments by Ministry of Health and Welfare by Government of India. He's been member special invitee, expert advisory committee or for nursing education and research for the 6 new aims. Then he's a member of expert advisory committee at the infrastructure for inter-institute networking and all on health information management system with each institute of national importance. He is also working as a group member under the National Coordination Center Pharmacological Program of India. Sir, over to you, sir. You can unmute yourself.
Thank you so much, ma'am. At outset, I would like to express my heartfelt thanks to Professor Suresh V and entire organizing team from Sumandip University. Just give me a moment to share my slides and then I'll start speaking. Can you see my slides?
Yes, sir. We can see your slides.
Okay. These slides are moving.
No. Those are not moving. So the first slide.
No. Okay, just then I'll again try to do it. Now they are moving.
Sir,
Vijay. Give me a moment, actually. I think there's a problem in slides. They are not moving. So I'll just fix it and then I'll continue the presentation.
Sir, we have many.
Yes.
Sir, we have made you as a host. You can start sharing. I think so. It will be visible now.
Okay, I'll just try.
Yes. Now you can share your screen and check.
Yes. Give me a moment. I'll do it. Can you see the slides?
Yes, sir.
But the problem is that they are not moving.
Now when you are clicking, sir, we can see.
Okay, perfect. So
Okay.
my apologies for inconvenience. Let us begin. You all have seen in last presentation by Dr. Aditya, he talked about evidence-based practices. Today, we all have seen that the time is changing. We make our clinical decisions based on the best evidences. That's why we have a pyramid of evidences. And best evidence is the meta-analysis, systematic review and meta-analysis. And there are organizations which help us to do the systematic review and meta-analysis. And JBI is one of the organizations who is offering 360-degree help into it. I'm very happy Sumandeep University is organizing and collaborating with JBI in this moment. Today, I ask Dr. Akanksha to mute, please. Today, the topic assigned to me is talking about nursing medication errors. We all have seen there are sufficient data to say that a lot of medication errors are happening in our clinical practices. And nurses are the key people who plays an important role, or I'll say bridge between prescription and reception of the drugs, either through oral route or other invasive routes, those are parenteral routes or any other route. And it's very important for us to prevent these medication errors, because sometimes these medication error could be very fatal in nature. This data says that in nursing error, about 34% errors are wrong rate of drug administration which are happening through infusion routes. Wrong time of administration in 28%, wrong dose in 25%, wrong omitted drugs are 24%, wrong fluid administration is 22%, wrong drugs are 21%, and wrong routes are 19%, and wrong patient is 19%. You can see from this data that about 20 to 35% of the errors are happening in all the drug administration, and this is a huge number. It can have a significant impact on the patient outcome. Now, these errors are up to 6.5% of the patients admitted in hospitals are affected with these errors. Almost all 33% of adults use 5 or more medications, increasing the chances of an error. 1/3 of all medication errors occurs during drug administration. And medication error increases average length of stay, that is 4 to 10 days for hospital who come across these errors. A medication error can be defined as any preventable event that may cause or lead to inappropriate medication use or patient harm while medication is in control of healthcare professional, patient, or consumer of these drugs. Now, if we look into the medications error, there are a long list of medication error can happen. It can be ranging from incorrect transcription of these drugs, that is when we are actually from verbal to the written or a paper digital format of the orders. Many times we come across today the verbal orders given by physicians. And when the nurses are transcribing, they can make an error, or a resident is transcribing, can make an error when he's consulting with a senior physician or senior doctor and then transcribing it or prescribing it. And then, sometimes the nurses record into their pre-drug administration checklist and then they use it. So that during that period, they may make it transcribing error. Mix up of the drugs, and there could be wrong mixing up of the drug. All the IV fluids are not compatible with every drug, and we need to have understanding, and deficit of knowledge can lead to wrong mixing of the drug. 2 drugs or drug with IV infusions. There is, could be a mistake in calculation of the drug concentrations. Incorrect or missing labels of solutions can, sometimes put the person to problem. Wrong or omitted past expiry drugs, and those can be administered because you miss it. Difficulties in handling certain IV preparation techniques, that is because of the multiple small vials which you have to mix into IV fluid. Incomplete delivery of container, sometimes you stop it in between because of some diagnostic test required, or the patient need to go for washroom or feed, and then you may left in between and forget it. Incorrect infusion rate, which is commonly happens if either the lack of knowledge or the nurse want to rush for some other work. Absorption problems, sorry for spelling mistake, the container or IV set can absorb. There are some of the chemotherapeutic drugs which can be absorbed by the plastic or the rubber tubings which we have, and therefore we do the priming, but still they absorb and the dose can be reduced. Incompatibilities of the drug with the pH of other drug, and there's an insufficient mixing of ingredients, and that remains undissolved and even sometimes can lead to embolism. Wrong storage of the drug, sometimes you store them at the wrong temperature and that can destroy it, either too high temperature or too low temperature. Contamination of solution can take place when you are loading from multiple drug administration vial. So you may use the needle which is getting into the vial is infected, and that can lead to contamination. Use of inappropriate dilutes. There are certain drugs which should be diluted only into the distilled water, not into normal saline. So if you inappropriately dilute or inadequate solution you use, it has to be diluted into 20 ml of solution or 10 ml of solution, and you use less solution. So these could be the common medication errors happening from this. Now, what are the causes of these medication errors? Most of the time, the studies has proven, most of the time, there is an interruption and destruction of the nurse during drug administration. Nurses care for not one patient, but many patients. And there may be, sudden call for other patient, or maybe doctor come on round, or other nurse call for some other work, and nurse get distracted. So she may make an error. Insufficient knowledge is again a major problem, specifically setting like India, where nurses are not soundly educated in pharmacology. And pharmacology is the subject which is not liked by many healthcare professionals, including large number of nurses. And difficulties in performing drug calculations, because the healthcare professionals always been poor into mathematics. They always, wanted to avoid the mathematics. And again, when they use calculations, they can make an error. Personal neglect, heavy workload, and staff turnover also could cause the medication error. Lack of confidence of student nurses in administering drugs lead to, errors, because person when be in fear tend to make more errors. But what are the solutions? There are large number of, strategies which we can use. We used to, read 7 hours, 10 hours. Now I'll say 15 hours of medication administration. That is right drug, right patient, right route, right dose, right time, right frequency, right assessment, right approach of drug administration, right education to patient about drugs, right evaluation after administration of the drug in sentinel reporting, sentinel event reporting, right documentation, right to refuse by the patient, and right principles of care and right prescription, right nurse clinician, and right universal precaution. These are the 15 R's nurses must remember while they are administering the drug. Now let us take one by one strategy how we can prevent these drug medication errors. I told you that destruction is a major responsible cause for medication error. So what nurses can do, they can wear a red kind of apron over their dress that the drug rounds are or drug administration rounds are going on, so not to disturb. So therefore, these errors can be reduced. Now we know that the electronics help us in a large way in right prescription, right administration. So when you use barcoded, dispensing, you first scan patients QR code, and then you scan dispenser, and dispenser will always give you that only the right drug, because LASA drugs sometimes can confuse. So technical assistance really help us not only in prescription but also in right drug administration. Now, barcode assisted medication administration, as I said, if you are making an error, it will alert you that this drug is not prescribed for this patient, or this dose is too high, or this dose is too low. So this is how this route is not appropriate. So this is how it can help us. Now, there are new nurses who just entered into system, and in India we have large number of fresh nurses working in healthcare settings, either it's a government or private, because nursing workforce is either aging or most of the nurses have migrated with an experience to other countries. So structured preceptorship is very important. The new nurses must be supervised by experienced nurses so that they avoid the errors. Now, nursing students should be thoroughly given theory and practice of medication administration by using objective structured clinical examination, so that when they become nurses, they don't make these errors. And what else you need to do? Ongoing education is very important, either for the student or registered nurses, to boost their confidence, skill, and knowledge in drug administration and drug calculations. Now, for accounting and for drug administration, it is always advised that you need to have a double check or even triple check if time permits you, so that human errors which are unconsciously happening also can be avoided. Whenever the written orders are taken, nurses always need to read back the order to prescribing physician to ensure that the order of medication is transcribed correctly. And nurse read back an order transcribed to the physician order form to another nurse, and that is a key or hallmark for accuracy of drug administration. LASA drugs, I would like to stress upon. There are some drugs which look same, and some drugs are sound the same, but they are not different. There's a list of drugs which has been given here, and acetazolamide, and if you say acetohexamide, they look same, they sound same, but they are not the same. They are very different drugs. So always we need to be very careful about this look like and sound like drugs. Now for prescription, called by the phone, it's an important that write down and then repeat the order to verify that it was heard correctly. Spelling of the drug is very important. So most of the time when either the nurse is taking the order on phone and transcribing, or a resident is transcribing, it's very important after you take an instruction, you read back and then get it verification that what have been said you have written and not the wrong. You need to say that verify and sign prescription in less than 24 hours if you have taken the verbal order of the drug administration in case of emergency. And only in case of emergency you should accept verbal orders, otherwise not in routine. And when working in a sterile process, only authorized persons should take and transcribe it, and standardized procedure is needed for transcription and administration, and only authorized medications should be given, and not during chemotherapy. You should not take them as a bubble order, because these are dangerous drugs. But you need to have always caution when you are transcribing on phone, that is spelling similar names, listening to the dose, and high-risk medications which are given through extensive invasive routes, and specifically the neonatal and pediatric drugs which can have a common allergies and these drugs should be carefully transcribed. So what are the hallmark for this or keys for listen very carefully, write down it, repeat it, and then finally confirm, and then you administer it. Place a 0 in front of decimal point. Always remember it, because this can lead to a major problem. Like 80 mg and point, if you just put here 0.80 mg, so always put a 0 and then point, so that error can be prevented. Because this is 0.25 or 0.5 milligram, and if it's 20, sometimes you can give the 20 milligram if it's not written in this way. Document everything, including the proper medication labeling was there. Eligible documentation is very important to safeguard you when there are legal suits of the patients. And ensure proper storage of medication for proper efficacy. I said specifically vaccinations and some of the drugs like insulin and many other drugs, because if you put them into too cool area or too hot area, they get damaged, and then their efficacy, half-life or bioavailability will be definitely reduced. So next is consider having drug guide available at all time. There are many drug guides available. I'm also fortunate that I could write one book which is a textbook of pharmacology, and this precisely talk about nurses when they deal with common drugs. So questions, if unsure regarding anything about prescription, if you're doubt about medication dose and route, please confirm it again. Don't assume it. There's no harm asking one person, and if it is doubt, again go to the next person. Even if resident sounds doubtful, then ask him to confirm to the physician or senior physician. Now, reporting adverse drug reactions is very important. ADR, there are centers which have been opened by Indian Pharmacopoeia about reporting these adverse drug reactions. That will, we will have more safer and safer drugs, and this helps us largely. Now, record more near miss. Whatever harms has, could have happened or happened, we need to report them. Institute safe medication practices in all settings and establish the safety culture in medication administration. That is through raising awareness, education, training, and audit. Now, reasons for underreporting, why we adverse drug reactions are underreported, that there's a lack of awareness about the mistake occurred. They don't realize that the mistake has happened. Unfamiliarity with medication administration error reporting process. Now, institutions are developing a adverse reporting system. They have a form, every patient, and then you fill it and report whenever it happens. Fear of personal and legal ramification, fear of having a negative impact on their performance evaluation. 34% of medication error aren't reported by nurses. This is an Indian data which I'm quoting. Now, if you see who all are responsible for this, there are people, there are technology, there are incident, there are organization, and it's a multifactorial phenomena why less drug adverse reporting is happening. The people don't do it because they have a lack of competence and experience. They have lack of understanding and unprofessional approach. The organizational culture is not conducive, and that's why there's a fear. So that's all about my presentation. Hope I could communicate briefly about which I wanted to say, that how we can have the prevention of medication error. Thank you so much for patience hearing. If you have any questions, I'm happy to take them.
Very well said, sir. Thank you very much for a very nice presentation. There are a couple of questions, sir. Do we need to develop barcoded drug delivery system for institutions, or is any softwares are available for it in India? Sir, unmute. You're muted, sir.
Ji ma'am, please repeat. I could not hear in between.
Okay, sir. Do we need to develop barcoded drug delivery system for institutions, or is any softwares are available for it in India?
Ma'am, there are softwares which are available by private players, and those can be used where the corporate hospitals even when they are using, where every drug which is supplied to a particular unit and they are consumed, they are barcoded. And nurses first, this helps in two ways. One is prevention of the medication error. Second thing is the drug inventory record. So pilfering can be prevented. So primarily the corporate hospital uses this to prevent pilfering, but it can have added advantage of prevention of medication error, because when you scan the barcode, it tells this drug is not prescribed for this patient. So then you can prevent giving the wrong drug. And if you are picking up a higher dose drug, let's say if it is prescribed as a Lasix 40 milligram, and you are picking up a only single vial, so it says that it's a low dose. You have to increase the dose because it is 40 milligram. So there's a system now, and technology is largely helping us in this direction, and this is very much available in India.
Sir, this adverse drug reaction, whichever are reporting, is very poor in this one. So why healthcare professional afraid of this reporting any adverse drug reactions? That is one question, sir.
Ma'am, can you repeat the question?
Adverse drug reactions or response reporting is very poor. So what is the reason why healthcare professionals are afraid of reporting?
Ma'am, I think in my second last slide, I have very well highlighted there. The problem is lack of awareness. Now, our Indian Pharmacopoeia is giving a lot of stress that there must be workshops and the awareness of healthcare professionals, specifically nurses, because they are around the clock available there, they start reporting it. The second most common problem in India is that fear of adversely impacting their career, because once they report it somewhere, they are fearful that it will come on us, that it is because of me that this patient had this adverse drug reaction. They don't feel that it could be just because of the medication itself. So once we develop a awareness, second is we develop a system there, and then we give them a confidence. So neither in most of the hospitals in India, I've been part of a national steering committee where Professor Gupta and Dr. Mehndi, and we all are the team, and I represent from nurses' behalf in the country. And we have taken a lot of steps, a lot of efforts and initiatives specifically into the tertiary care hospitals and government hospitals, where to increase the awareness of nurses and creating a system where nurses can report. In most of the hospitals, there is no system to report. So if there is a adverse drug reporting form in every patient's file, at least they can then do it. Or there's a number displayed that at this number you can inform, and then the pharmacology people can come and then they can take the detail. So we need to first is developing a confidence, awareness, and creating a system will definitely help. But yes, today the reporting is very, very low.
I think so. As we are moving towards the more technological aspect, I think so we can do something with app application which is friendly for all of us to use it. As a suggestion, we don't know.
No, it's very true. I was little careful not saying it because technology is not into reach of everyone, even district hospitals. But yes, we should begin from tertiary care hospitals and even for common men. In the last meeting, Dr. Rajiv, who is the chairperson of Indian Pharmacopoeia now, he himself said that why don't we work upon creating an app where, like, the app created during COVID. So Arogya Setu, similar app, in anyone, even a common patient who is receiving drug at home can have opportunity to report the adverse drug reactions. And definitely Government of India is very keen and working on this. And I appreciate highlighting this at this point of time.
Welcome, sir. So thank you very much, sir, for your presentation. It was really good listening from one of the good nursing staff who is giving such a good oration. It was nice to meet you, sir. Thank you very much, sir, from Sumandip Parivar.
My pleasure, ma'am. And unfortunately, next week I'm traveling to Adelaide. And
okay.
And
so you
maybe
can visit
meeting
the
Professor Jordan.
also. You can visit JBS.
Yes, it's there in my plan. I'll be visiting Flinders University and then have a plans to meet Professor Jordan. If I'm meeting, then I'll convey the regards from my behalf and your behalf.
Okay, thank you very much, sir. Sir, can you please make Sumandip Vidyapit as host, because we have made.
Sure, ma'am. I'll do that. Just give me 1 minute, I'll do it.
Yes, sir.
I have done, ma'am. You please just check it.
Thank you very much, sir.
Welcome, ma'am. Namaskar. Thank you once again for giving me opportunity, and thanks to all the participants for listening patiently. Namaskar, Jai Hind.
Thank you, sir. Now we are going to present a video from Dr. Joy Jordan, who is an ex-director of JBI, who has sent this message from the JBI gLocal solution. So we are going to have a small video presentation from JBI.
Welcome to the JBI gLocal Solution Room. I'm so sorry that I'm unable to be there with you in person at this event, but I'm delighted that we can now work in collaboration with our local entities to connect with you to the discuss the important challenge of getting research into practice and hopefully to identify some solutions. For those of you who are perhaps unfamiliar with JBI, our vision is to provide better evidence to achieve better outcomes and a brighter future. Our mission is not only to promote, but also support the use of evidence at the point of care globally. But of course, we can't do that alone with just our small team of around 35 staff here in Adelaide. So international collaboration has become critical, not only to us, but also to the broader evidence-based health endeavour. In thinking about what I might say in this opening presentation, I thought it might be useful to first attempt to define for you what localisation actually is. Localisation was popularised by the work of sociologist Roland Robertson, who traced the roots of localisation from a Japanese business term, doshakuka, which emphasises a global outlook adapted to local conditions. Localisation stresses the idea of contemporary globalisation influencing the local level of society and the localisation of globality. So what does localisation have to do with evidence-based healthcare? The JBI model of evidence-based healthcare recognises first and foremost the critical relationship between research and practice. The yellow wedge at the top of the model speaks to both the globality and locality of evidence-based healthcare. In simple terms, EBHC begins and ends with the needs of health professionals, health services, and health service users. If we as researchers and synthesists are not engaged with those working in practice, if we are not responding to your knowledge needs, then we will never achieve sustainable improvements or impact where it matters most. That is why events like the Global Solution Movement are so important to us. Answering the right questions, answering questions that matter as they relate not only to the effectiveness of interventions, but also the feasibility, the appropriateness and meaningfulness of those interventions is vital to the success of implementation efforts. Working in collaboration with you to determine what those questions are, then supporting you to implement the answers is the only way that we can achieve our vision. So in thinking about the application of evidence, context is key. At JBI, we're cognizant that it is our responsibility not only to provide health professionals with the best available evidence to support, but also to support you in its use. Again, that is not possible without connection, without connecting in person, without acknowledging and accepting that different cultures and clinical environments present different challenges. And we hope that this event, or rather this series of events taking place around the world this week, contributes to overcoming some barriers, to help us understand the challenges we're facing and to provide opportunity to generate solutions together in partnership. I think it would be remiss of me in our current climate not to touch on the impact of COVID-19. No country or region has been spared throughout this pandemic. The crisis has laid bare stark weaknesses between countries and across different systems, and we've witnessed the disproportionate ability of health services to respond. We've also seen firsthand and in real time both successes and failures related to evidence implementation. To achieve a new normal will require a coordinated, coherent and cohesive response that is effective globally for sustainability. But that global approach will require local expertise in order to be successful. For decades to come, I think we will undoubtedly continue to critically reflect on why some countries, including less resourced countries, have been able to respond more effectively to COVID-19, while some well-resourced countries struggled. And I suspect, at least in some instances, that this will relate to how and whether evidence was considered and utilised to make policy and practice decisions. The last 18 months have almost been like a stress test for EBHC. in some respects. And I think that there are many lessons that we have learned in relation to how and when evidence is synthesized. The model of JBI partnership employed by the JBI collaboration leverages, I think, the strengths and competencies of our global community. It values difference and promotes equity, diversity, and inclusivity. I have borrowed this diagram from authors in the education space who speak of local knowing, local acting, and local being. That is the ability to contextualise different types of knowledge, to work together across cultural, social, national, and geographical contexts to identify sustainable solutions. And what I like about this, what I find really appealing, is that it speaks to the pragmatism of how we connect in order to make meaningful use of information. The idea of the solution room, bearing in mind that there is no magic bullet for translating research into practice, it came from a powerful conference session concept designed to engage and connect attendees, but also to provide peer supportive advice on pressing issues. While our event doesn't strictly follow the original format, the concept of being solution-focused and pragmatic was really attractive to us at JBI. Pairing that with real-life challenges related to implementation seemed to be an obvious choice and a perfect opportunity for us to engage with those we seek to support, going back to our vision model. There is learning to be achieved on both sides of the podium today, I believe. And an opportunity to share experiences and co-create partnerships for purpose to achieve better health outcomes by applying global knowledge. Unfortunately, these days I don't have a lot of opportunity to connect with people in person, but I'd love to hear your thoughts about how the event went and to hear about any solutions you perhaps came up with. So I encourage you to reach out to connect with me via one of the options that are there on the screen. And again, I wish you a really successful event. Thank you.
Thank you very much. Thank you very much. Now we will be starting with the next session by Dr. Jain sir. So we will be starting with the next session now. Is Dr. Jain Patharkar sir, who is presently working as assistant professor in the Department of Pharmacology at SBK's Medical Institute and Research Center, Sumandi Vidyapith deemed to be university. He is working as deputy coordinator as Adverse Drug Reaction Monitoring Center at Department of Pharmacology under Pharmacovigilance Program of India. He had done MBBS from BJ Medical College, Pune, and MD in pharmacology from SBK's Medical Institute, Vadodara, Sumandi Vidyapith. He served as a chief medical officer in Srimati Uttaradevi Charitable Trust, Hyderabad for 14 years. He has published articles in many of the national and international journals. Recently has completed even the yoga teachers training course from the Yog Niketan and from Sir Sayajirao Institute of Research in Yoga, Ayurveda and Naturopathy, Music and Allied Science. Over to you, sir.
Yeah, thank you, Shivam, for giving such a good information regarding me. And we have very good sessions in the morning by Dr. Bikas Mehdi. He had, as usual, in his lucid language, with apt these examples, he has given very good information regarding medication error. After that, we had a very good session by Dr. Mr. Professor Sharma. Regarding medication error and how administration of drugs can cause various medication error nursing point of view, he had given very good information regarding that. So I'll be talking about the strategies to reduce the medication error in developing countries. So this medication error has a huge problems nowadays we are facing. This So medication error is a preventable event that may cause or lead to inappropriate medication use or patient harm. So this can be prevented. Medication error that is leading to the various adverse drug reactions that can be prevented. So if we take due care during various stages of medication, like prescribing, we have seen in various studies during prescribing, we got to have these various medication error, and that lead to the adverse patient outcome. Also during communication, as it was very well said by Dr. Professor Sharma, that if we don't communicate with the nurses properly, the proper order is not being given to the nurses, and if there is any communication gap, that can lead to various medication error. Also, product labeling should be proper, packaging, nomenclature, compounding and dispensing. Though we get very less medication error due to dispensing, that has to taken care of. Also distribution, administration and education. Education of medical staff, including nurses, then pharmacies, and also the consumer who is going to use the medications. That is also important. That also plays important role due to the medication errors. So this is the definition that is given by National Coordinating Council for Medication Error Reporting and Prevention. So another definition that is given by the European Medicines Agency, that is medication error, is an unintended failure in the drug treatment. So here the word unintended is very important, that there is no intention to fail the drug treatment. So unintended or unintentional error that occurs during the treatment process that harms the patient, that is that has to be seen. Then various during this study, incidence of medication error in critical care unit of a tertiary care hospital, we have seen around 6.11% patients faced with the medication error. Out of this, we have seen that transcription errors and prescription errors got the major major portion, while indenting and dispensing errors are very less. Also, administration errors, those are 14%. Also, in another study, we have seen that 48.39% medication errors are there, and NCC MERP criteria, when it is applied, then we have seen that administration errors of category A and B are more, but the distribution of category C and D is also quite alarming. So this National Coordinating Council Medication Error Reporting and Prevention Index, while categorizing, Dr. Mehdi also had given good information regarding this, that these medication errors can be categorized into the various categories from A to I, where A, there is no harm to the patient or no error had occurred, but in B, C, D, their error had occurred, but patient doesn't get any harm. While in another errors like this error E, F, G, H, I, so their error had occurred and there is a harm to the patient. In the category E, error occurred and that may have contributed or resulted in temporary harm to the patient and required intervention. While in category F, an error occurred that may have contributed or resulted in in temporary harm to the patient and required initial or prolonged hospitalization. In category G, we have seen that an error occurred that may have contributed or resulted in permanent patient harm. So these are more serious these medication errors that occurs. Then category H, an error occurred that required intervention necessary to sustain the life. So these are very serious adverse medical errors. And category I, that can cause life to the patient. So whenever we are categorizing these medication error, we have to see the seriousness of that medication error, and that has to be notified properly. So how do they occur? How the medication errors occur? There are various stages of administration of medication. Like first, physician will prescribe the medication, then their error can occur if the physician don't have the proper knowledge, or if he write the incomplete prescription, then transcription error can occur. These are the major medication errors that are occurring. Then dispensing documentation. The Dr. Professor Sharma had told that documentation of each and every step of administration of a drug is very much essential, and that will save you from the legal any consequences that occurs after the medication error or the any harm to the patient. If you have properly documented, that can save you from the legal consequences if you've done your job properly. Then storing and indent error, those are very less, but we have to take due care while storing also. And administration of a drug after receiving proper physician's order, that we have to take care of. And these most common preventable causes of undesired adverse event of during the medical practice, they pose huge burden on the healthcare system. So we have to try to prevent all these medication errors, and these are all preventable medication errors that we can prevent and save the lot of economic burden on the hospital. Because the developing countries like India, we have very scarce hospital facilities, and a lot of people are unable to approach to the hospital because of during this second wave of COVID also, we have seen a lot of patients were there, and we are unable to find the bed for those patients. So if we are adding to the burden of hospital due to the error that we have not serve our job properly, then these medication error do occur, and they will put a lot of burden on the healthcare system. Then these prescription errors, these are clinically meaningful prescription errors that occur when as a result of prescribing decision. If we are not updated our knowledge, or if we have very this old knowledge about the some disease condition, then these prescription decisions, those are bound to happen. Also, prescription writing process. Though we have now introduced various digital methods to enter the these prescription order, so that will save us from these writing processes where illegible handwriting that can pose many medication errors, because that information is not given properly, or that is not understood by the nursing staff, then pharmacist, and then there will be a medication error. So this unintentional significant reduction in the probability of treatment being timely and effective, that can cause these prescription that can be caused because of these prescription errors, and that also increases the risk of harm when compared with the generally accepted practices. So these prescription errors include incorrect prescription, illegible handwriting, drug allergy not identified, particularly if the patient is having some allergy and that is not notified on his prescription sheet or his medical record, then the next physician who is going to look after that patient is going to write that medication, and that can cause medication error. Also, we do have, as very well said by Dr. Mehdi, that we have a very huge number of irrational drug combinations that can also pose various prescription errors. And we have the habit, particularly the resident in the various hospital, because they are burdened and they have very huge this thing work to do. There are abbreviations; those are followed by these resident, and these out of list abbreviations can lead to various prescription error. As for the patient's safety, Dr. Sharma, he has given 15 points the nurses should look into while administration of the drug. That is correct, right drug, right patient, right dose. While the prescription errors that occurs because wrong patient has been chosen for that drug, wrong dose, or wrong frequency. Also, the route of administration may be wrong. That can lead to the various medication errors. Then incorrect prescriptions that occurs and how to avoid it. How one can avoid these incorrect prescriptions that continuously educating these medical staff and training of these prescribers and use of online aids. Now we have various apps available on the Google store that we can subscribe for that app, and we can get the appropriate information. Online aids are available for our help, and that technology can be used to prevent various prescription errors. Also, introduction of automated system. This is introduced in various developed countries, and they don't have any record that is missed because of this automated system. And also we can we can follow this uniform prescribing charts if these automated systems is not available in the developing country like India. In some of the PSCs, primary healthcare centers, we don't have these automated systems, so we can follow the uniform prescribing chart. That will help us. So this can avoid the transcription and omission errors. Also, we should have the proper feedback control systems and immediate review of the prescriptions. So this review of the prescription by the second person, because we are being human, there are very likely chances we can commit mistakes. So that is bound to happen, and with a lot of burden, that is bound to happen. So there should be another clinical faculty, say clinical pharmacist, who can review the prescriptions, and if there is any error, that can be intimated to the physician, and further that chain can be broken to prevent the medication error. Also, regular prescription audit should be performed this in the hospitals, so that we come to know what are the reasons that are leading to the prescription errors. So how we can avoid it? Error reporting system should be in place. Whatever errors are occurring in the hospital, internal as well as external, this reporting system should be followed. Then reporting should be usually voluntary and confidential. There should not be fear in the mind of prescriber that I will have to face any legal complications if I am going to report the medication error that had occurred. But that will save in future a lot of lives if you are going to report, and it should be kept confidential. So the prescriber should have that confidence that I am not going to face any legal consequences out of it. Also, reporting should be timely and evaluated by the expert to identify the critical conditions, and it should allow the system analysis. And whenever we are getting all these medication errors, that should be notified and that should be informed to the prescriber. Unless and until we give the feedback to the prescriber, those medication errors, they are bound to happen. So what are the conclusion of analysis and what are the errors that had occurred, that should be informed back to the prescriber. So in future, those errors can be minimized. So here we are here to discuss about the evidences that will reduce the risk of medication error in general practice. So how we can generate the evidences? So there are various strategies. Those are followed by the European medicine agencies, and also there are this thing assessment of the medication error in the context of pharmacovigilance. As Dr. Mehdi told that we have started with the pharmacovigilance program of India in 2010, and now we are this pharmacovigilance wing is developing like anything. We are there in material vigilance. Also, we are working on hemovigilance. So all these sub divisions are developing under the pharmacovigilance, and that will help us in a lot to prevent the medication error, and in long run that will be useful for the patient safety. What is our main goal? Why we are doing these evidence-based practices? That we should safeguard the patient. We are here to save the life of patient, and there should not be any error on our part that will endanger the life of the patient. So this assessment of medication error through pharmacovigilance will help us to prevent the various medication errors those are occurring. So in one of the studies, it has been found that 18.7 to 56% of all the adverse events that occur among the hospitalized patient result from the medication error. So this is a very huge number, and we can save a huge amount and suffering to the patient by properly doing the medication, this prescription review and audit. So these errors can be preventable. So this European Medicine Agency, they have published one good practice guidance. This guidance that was published by European Medicine Agency, that plays a pivotal role in reporting, then recording, coding, and reporting and assessment of medication error in context of pharmacovigilance. So I will be speaking about this guidance document by European Medicine Agency, and we can apply such type of these strategies in our countries also, which will help us to avoid these medication errors. So this guidance adverse event that defines any untoward medical occurrence if the patient or clinical trial subject that is administered a medicinal product which does not necessarily have the causal relationship with this treatment. So this is the difference between adverse event and adverse drug reaction. What is this adverse drug reaction? It is a response to a medical product which is noxious and unintended. So it should be unintended response, then only it is an adverse drug reaction. If intentionally knowing the contraindication and knowing the overdose that is being given, it is not considered as a adverse drug reaction. This includes adverse drug reaction which arise from the use of medical products within the terms of marketing authorization. So for what this drug or this medical product has been indicated, if we are using outside the terms of marketing authorization, including overdose or off-label use, most of the time some of the drugs being used off-label, which is not there in the label, then it should not be considered as a medication error, or sometimes misuse or abuse can occur, or occupational exposure, that is not considered as a medication error. So then what is the medication error? It is unintended failure in drug treatment process that leads to or has the potential to lead to harm to the patient. So it should be unintended. If someone is taking intentionally, or some patient stop the treatment intentionally, if patient is taking antibiotic and he stops, he feels better after 2 days, and if he is not taking those drugs for a full course that is advised for 5 or 7 days, then this is intentional and it will not be considered as a medication error. So to understand how the medication errors that are causing adverse drug reaction and how one can prevent it. Few of the adverse drug reactions which are not preventable, those are because of that medicine or genetic makeup of that patient that can lead to the adverse drug reaction and that will harm the patient. But some of the adverse drug reaction which are occurring because of the process of medication. While prescribing, if you are writing a wrong prescription or incomplete prescription, that can lead to the adverse drug reaction that which is very much preventable. Then there are medication errors that are occurred, but there is no harm. And some of the medication errors that can be interrupted or intercepted errors, like they would have caused the this harm to the patient because they are intercepted by the some of the medical personnel. So they are potential adverse, they can cause the potential adverse drug reactions. So this way, if we are doing the regular review of the prescriptions during the process of medication, one can intercept those errors and harm to the patient can be avoided. Like if the nurse has given a wrong she put the medicine in a syringe which is not intended for that patient A, or that is intended for patient B, and then staff nurse or senior nurse come and he notifies that it is not intended for that person, then that can intercept the error. And some of the errors, those are potential errors which can be avoided if that doesn't reach to the patient, and these errors can be avoided. So preventable medication errors, these are adverse reaction that results from the error in the medication use process. So we should understand it is not the adverse drug reaction because of that medicine. It is only because of that process. If we follow a proper SOP during medication, then these errors can be avoided. Then non-preventable adverse drug reactions are generally those are occurring because of that undesirable effect of the medicine, for which probability of harm to the patient is known and accepted, and will likely to occur depending on the frequency of adverse drug reaction on other circumstances such as co-medication if we are giving. And polypharmacy is now a problem in our Indian prescriptions also. Sometimes the physician used to prescribe the medicine on patient demand, that the patient is not feeling well or patient is malaise and he demand for multivitamins. To please the patient, sometimes physician used to write the multivitamins which are not indicated to the patient. So that can also lead to various adverse drug reactions. As I said, intercepted medication errors, those are also called as near miss medication errors. These are recognized and intercepted before those are reaching to the patient. A potential adverse drug reaction that was prevented, and this is referred as intercepted errors or near miss errors. So we can avoid these errors if they are we come to know about those errors in time. So that can be intercepted and further harm to the patient can be avoided. There are certain potential errors that can be avoided, or those are not causing any harm. Whether we have to record such potential errors? Yes, we do have to record such potential errors, because in future those errors, if are going to happen, that can be avoided. Sometimes some medical products, those are giving dosage or labels that is referring some dose in milligram per ml. And if physician want to change that, the other this other brand physician want to change to other brand which is giving the dosage in milligram per dose. So before switching the medication, it is necessary to perform a dose calculation to ensure that applied dose remains unchanged. So such potential errors can occur, and we can avoid such potential errors. Then after these understanding of the various types of errors, classification of medication error is also very much essential. Whenever we are going to report the medication errors, that should be classified properly. Sometimes medication errors occurs with the ADR that will harm the patient, and then medication errors occur, but that will not harm the patient. So medication errors without harm, and as I said, intercepted or near miss medication errors that can be classified as a intercepted medication error and potential medication errors. So these are the classifications of medication errors that can be reported. So how to break this chain? This diagram is showing if the error with adverse drug reactions that have occurred, but that is not intercepted. So that will harm the patient. So this classification, when we break this chain, as we have seen in the intercepted error, if we come to know about that error in advance, and if we have various technologies in place where we can, there are alerts which are, we will get the alerts through this computer assisted system. So we'll come to know that error had occurred and we can intercept that. So this intercepted error will be there, and sometimes error can be avoided as we have the knowledge about that product. Some products or some medicines are having the name which are very confusing. So these can lead to the potential error. If we come to know and we can change the name of that drug by giving the proper notification to the competent authority, that can be done, and these potential errors can be avoided. Then recording of medication error reports. So after getting the medication error, recording is also very important. These medication errors are associated with the use of medicinal product, may be reported spontaneously. When we come to know any medication error, like a physician or nursing staff, they come to know about these medication error, that should be reported. It is not required that any competent authority that is going to ask to report. It should be a spontaneous process, and that will help the patient or safeguard the patient. And if we are safeguarding the patient, we are saving ourselves also. So there will not be any legal complications in future if we safeguard the patient. Or it may be reported in context of solicited report of suspected adverse drug reaction. Those are derived from the organized data collection systems such as non-interventional studies or registries. Some these suspected adverse drug reactions that we are regularly reporting, serious or non-serious. These suspected adverse drug reaction is because of direct response to the medicinal product or caused by an error. That should be recorded, reported, and assessed. So these suspected adverse drug reactions we are regularly reporting through the adverse drug reaction VG flow system is there of pharmacovigilance, where we are reporting these adverse drug reactions. Then recording of these medication errors, that is also important, because marketing authorization holders and national competent authorities that will use this medical dictionary for regulatory activities. So these terminologies, those are used worldwide by regulatory authorities and pharmaceutical companies, which will use these medical dictionary terminologies for recording various medication errors. Healthcare professionals and patients and consumers, which are not required to use this medical directory for reporting the adverse drug reactions which are reported spontaneously. So these terminologies stakeholders may use for coding the medication errors, error reports, which will depend on the purpose for which they are going to report it. There are various stages during which these medication errors will occur. So medication error may trigger a series of events. There may be more than one stage in the drug treatment process affected by an error. So when prescriber prescribe the medicine, so error can occur if it is not intercepted. If we physician, if there is no proper review of the prescription by other expert, then that will go ahead, and that will lead to the dispensing error, and consequently that will lead to administration error. So this error can be coded at the different stages. But primarily, one should know to capture the primary stage of medication error where medication error had first occurred. So first, if there is a prescription error, it should be coded accordingly. Then medication error in context of contraindication. So whether we are going to report, if we have reported, we have given a drug which is contraindicated in that patient, or with the some of the concomitant medication that is going on, and if we happen to give the drug, whether we are going to categorize it as a medication error? No. If it is unintended, that the physician or nurse doesn't know about that new contraindication that had that is just arrived, then that can be classified as LLT, low level term contraindicated drug administered. But if the prescriber knows that medicinal product is contraindicated but intentionally prescribe it anyway, this is considered as a off-label use. So it is not a medication error. Then sometimes treatment non-compliance of the patient. Patient non-compliance with the prescribed treatment or course of medication may result from variety of factors, and common scenario is intentional non-compliance. As I said, that after taking antibiotic course, after 2 days, patient feels better and patient stop the drug on its own. So that is not a medication error. And sometimes some of the Ayurvedic practitioners, they are saying that you can stop the antihypertensive drug after doing some of the regular changes in your day-to-day habit and doing some exercises and all that. Then also, if the patient is stopping that drug, then it is not called as a medication error. So such error should not be committed, and patient should stick to the physician's order, and there should be adherence to the guideline, whatever prescribed by the competent authority. And is the another aspect is there, is the intentional re-challenge considered a medication error? So while doing the causality assessment, we will see whether there is a de-challenge is performed or whether there is a re-challenge that is performed of the medical product. So that is a regular process that we are following. What is this de-challenge? It is nothing but the withdrawal of the drug when the patient had some adverse drug reaction, and when there is a partial or complete disappearance of the adverse drug reaction. If it happens, then we can say it is a positive de-challenge. And when we subsequently reintroduce that drug, which is unethical, we are not following this regularly, or we are not doing the re-challenge of a drug. If the subsequent reintroduction of the suspected product re-challenge occurs, then it is called as intentional process. So intentional re-challenge process, it is not a medication error. Then lack of efficacy. If certain medicinal product that has a less efficacy or efficacy lacking in the efficacy, that is not considered as a medication error. But if it occurs because patient inadvertently or because of lack of proper guidance to the patient, if the patient doesn't take the proper dose of a medication and there is some efficacy is lost, then it can be coded as a medication error. Or else in other cases, when the efficacy is lacking, then it is not considered as a medication error. Then accidental and occupational exposure versus the medication error. If the patient is exposed to a particular drug or particular agent that had caused the harm to the patient, then it can be coded as a medication error, but occupational exposure which is occurring, that is not considered as a medication error. Then off-label use versus medication error and misuse. So off-label use relates to a situation where the medication product is intentionally used for medical purpose and not in accordance with the authorized product information. So this should not be referred as a medication error. The focus is on the intention of healthcare professional to use a product outside the authorized conditions of the use. This is medication error is usually any unintended failure in the drug treatment process that leads to harm to the patient. So this is off-label use or misuse. For that reason, it is not a medication error. So this medication error should be clearly distinguished from the misuse. Misuse relates to the situation where the medicinal product is intentionally or inappropriately used, not in accordance with the authorized product information. The focus is on the intention of the patient or consumer to use the product outside the authorized conditions. This can be said for the cases where the patient has misunderstood the instruction how to use the medicine correctly. This should be considered as an error, and appropriate this coding should be done. So if the patient is not informed if entry-coated tablet is there, and patient is not informed properly how to take it, and if the patient places the tablet inside the mouth and then consume it, that will lead to the error. So that can be coded as a medication error. So proper information should be given to the patient. And this is a major problem nowadays we are facing, because the number of patients are there and the physician don't have time to properly give the information regarding the medication. So what one can do when a doctor prescribes the medicine and there is no pharmacist who can give the information, doctor can ask the patient to visit him again, and he can inform how to take the medication. And this is the major reason for the medication error, and which is preventable, and that can lessen the burden on the healthcare system. Then overdose and underdose versus medication error. So overdose are not necessarily considered to be medication error unless unintentional overdose occur as a consequences of error. Both over and underdose may unintentionally be result of preceding medication errors, and relevant term for this is a high-level term, that is maladministration, may be chosen in combination with associated medication error. Sometimes if we are giving a medication by some dropper, and if to the neonatal patient, and if the dropper is not marked properly, and if you are giving the dose and that leads to the overdose to that patient, so it will be considered as a medication error. That already I told that product quality issues versus the medication error. So product quality issues are abnormalities that may be introduced during the manufacturing, label, packaging, shipping, handling, and storing process of the medical product. So accordingly, it should be coded for the medication error. Then medication error related to the invented name. Some of the manufacturer that gives the name to that product, or that is brand name. So those product name confusion, if it is there, if the name of the previous product is similar to that product which is having different active ingredient, then that may lead to the medication error. So that should be reported to the concerned competent authority, and competent authority should take due action to change the name of that product. Then follow-up of medication error reports. So reports of medication errors which are associated with suspected adverse drug reaction should be routinely followed to ensure that the information is complete or possible with regards to symptoms, treatment outcomes, and context of occurrence. So this report should be followed regularly, and particularly this is important when signal has arisen. What is this signal? whenever we are reporting various adverse drug reaction and the signal review committee come across some adverse drug reaction which is continuously occurring because of particular product, then they will raise this signal and they will intimate it to the prescriber. So that will save various adverse drug reactions that can occur because of these drugs. So this can be done in post-marketing surveillance, and also the marketing authorizing this company that they should notify these adverse drug reactions which are occurring at the various stages of these trials, like in post-marketing surveillance. Then what are the parameters that has to be followed when reporting the medication error? Case report of medication error should include, where possible, the following information, that is classification of medication error. We should able to classify these medication errors, whether medication error occur with the adverse drug reactions or they are occurring without harm to the patient. That should be classified properly. Stage of medication process where the error had occurred. As we have seen that medication process has to go through the various stages, right from the prescription by the physician till the patient consume it. So various stages are there. So we have to see where this error had occurred. Then what are the contributing factors that has to be seen. And reported adverse drug reactions if error affected the patient or consumer with the clinical consequences. That means if ADR had occurred. Then potential for harm, if the potential error or intercepted error did actually happen, but it does not reach to the patient or consumer. Then also it should be recorded, because that will save the future medication error that can occur. Then medical products, those are involved, that should be taken into account. And batch number if the error is due to the device failure. Nowadays in material vigilance, we are seeing a lot of errors that are occurring, as Dr. Mehdi told that one of the fetus that died in the incubation. So that is because of the medication product failure, and some of the patients who are being placed with the these exogenous pacemakers, and if that battery fails, then patient will die. So these are very serious adverse reactions that are occurring because of failure of the device. So one can attain, or one can understand why these device failure, and that those should be reported properly in time. So what is the role of these healthcare professionals in reporting? So these healthcare professionals should be encouraged to report the medication error, and all the information that is given by the healthcare professional, that is confidential, and there is no any, as we say during reporting of ADR also, whatever ADR are reported, the reporting person is not held responsible for that. So these reports should be encouraged. These medication errors should be reported, which they either commit themselves or which may be made aware of through the consumers, or when patient come to you and tell that the particular medication error had occurred, that patient had suffered because of this, that should be reported. And one should not have fear in mind that it will have any legal implications. Then potential liability aspects regarding reporting of medication error. This is very important aspect of this medication error reduction. How one has to reduce. Unless and until we are going to report the medication error, we are not going to look into the aspects which are going to reduce this medication error. This suspected adverse drug reaction report is submitted and classified as a medication error solely and exclusively to ensure the marketing authorization holders compliance with the requirement of good pharmacovigilance practices. This is nothing to do with the your knowledge or your mistake that you have committed. This is only for the marketing authorization holders, so that they will comply with the pharmacovigilance practices. Classification as medication error is no way intended or shouldn't be interpreted or constructed an allegation or claim made by the marketing authorization holder, that any third party, for that matter, healthcare professional, has contributed to or in it is to be held liable for the occurrence of medication error. So this disclaimer is there whenever you are reporting medication error, that you will not be held responsible for this medication error. So one should report these medication error whenever they come across or whenever it is being notified by the patient. So these medication errors should be reported. So what are different strategies? We have seen that medication errors should be reported in the view of pharmacovigilance. Then regular medication reviews and reconciliation. This is a very important aspect so that we can avoid the prescription errors. Because being human there and we are burdened with a lot of patients, particularly we will see in the government setup, where in the lot of patients are there and these OPDs are crowded with the patient, where physician is unable to attend the patients very properly, and there are these errors are bound to happen. So these review of the medication, whenever prescriber or physician has written the prescription, when it goes to the pharmacist, there should be some expert who can review that prescription. It is not the matter it is not the matter of ego or regarding knowledge of the physician, because of the burden of the this physician. And as Dr. Mehdi also told that in their hospital, these residents who are working for 48 hours throughout their residency. So this is very difficult to pay attention, and these errors are bound to happen. So proper medication review is very much essential to avoid these errors. So if one expert is there who can review and get back to the physician, these errors can be avoided. So these studies, various studies have shown that pharmacist-led medication reviews, those have reduced the hospital admissions. So one has to see the medication reviews should be there after writing the prescription. Then medication reconciliation, this is a formal process of establishing and documenting a consistent definitive list of medicine across the transition of care, and then rectifying any discrepancies. So this medication reconciliation, it is a formal process where one can see whether we are following the SOPs, we are doing the this medication process properly. So reconciliation should be there, and this increased medication discrepancies at discharge, particularly it has been seen that whatever prescriptions are written in the patient file, that is being written by the resident, same prescription will be written in the this discharge summary, and polypharmacy will be there, because there is no any the mistake or any error or any wrongdoing of the these consulting doctor, because of various issues and burden of the patient. This will happen. So there should be a proper reconciliation, so we'll come to know what are the errors and why they are occurring. Systemic review found that these medication reconciliation system reduce the medication discrepancies as well as potential and actual adverse events. So that can be avoided, and that will avoid the burden that is occurring on the healthcare system. Now, Dr. Mehdi also told that computerized provider order entry. That is, some of the corporate hospital, they are following these technology, they are using these system, and also that is supported by clinical decision support. Because for human brain, it is very difficult to understand all the medicines which are being available. In India, there are few 60 to 80,000 medicines, and various FDCs are available. For human brain, it is very difficult to understand each and every ingredient of that medicine. If we have the clinical decision support, which is given by the now artificial intelligence is there, which is they are developing a software which can give you a proper, if you put in particular clinical symptoms, they will give the proper diagnosis and proper treatment that has to be followed. And with your experience, you can compare that. Accordingly, one can take the decision, and all these automated system will avoid these medication errors. Then that will also promote the evidence-based treatment. So in various trials, it has been seen that computerized intervention found a reduction in the medication error in half of the studies. So if we have this computerized system, various errors that are occurring because of illegible handwriting, or if the proper order is not communicated to the nursing staff, if we are putting those orders in the system, then there is no chance of error that can occur. So that will save the patient also. Education and training of the stakeholders of the healthcare system, including consumers. So educating the healthcare provider, it is a regular and unending process. So once we are in the medical field, we have to learn throughout our life. So this is unending process, and that has to be followed. And what is very important, that we should train the patient. Whatever patients are coming to our hospital in the patient area, that we are following. To our AMC center, we are visiting hospital and in the patient area, and we are educating the patient how to take the medication and what are the medication that can cause the adverse drug reactions. What are the commonly occurring adverse drug reactions? If they are educated, then that this medication error that can be avoided. Also, they should be educated about how to take the medication. Once they visit the physician and they go at home at their places, and they are very much confused how to take the medication. So that should be properly communicated to the patient. So education of consumer or the patient is also important. So some of the review that found that some evidence that patient self-administration of medication can be safe or safer than usual care following appropriate education and preparation. So over-the-counter drugs, those are very easily available in our country like India. So some of the scheduled age drug, antibiotics, those are also available on the over-the-counter. So if you are educating the patient, then it is going to avoid various errors that are occurring. Then special attention to the key points to reduce the medication error, like particularly injection, where these serious adverse drug reactions are occurring because of injection. Because of tablets, those injections, adverse drug reactions those are occurring, that may not be life-threatening. But in the injection, as you are giving it into the parenterally, the special precaution has to be taken, like double checking and appropriate labeling. Whenever patient come in the casualty, and if you have to give various life support and various medications, then that injection syringe should be properly labeled. If you are not labeling, and that attending nurse goes to other patient who had come with some other injuries, and another nurse come to that place, and if she inject that injection, and there are chances that medication, these errors are going to happen. So proper labeling of that syringe is also important. So error associated with injection, like risk of infectious diseases transmission. It has been found that there are around 340,000 HIV infection that have occurred in 2018, and 15 million hepatitis B infection that had occurred in 2000. This data is from the WHO Global Burden Disease Study. So this is very important to attend these injection, or whenever we are giving these parenteral this administration, one should be very cautious. We should not, there should not be any iatrogenic problem. We should not introduce any problem to the patient because of these error in the process. Also mistake in the weight dependent dosing. So particularly in pediatric patient, that is going to occur when we are calculating the dose. We should see the weight of the patient properly. Then incorrect reconstitution, as Dr. Sharma told us, that incorrect reconstitution, that can also lead to various medication error. Then wrong route of administration and problems with the storage. Some of the vaccines, those are not properly stored in various remote areas. We don't have that facility. So proper storage, and then we will lose the efficacy of that vaccine if we are not properly storing. So the proper cold chain storage should be maintained. Other issues related to injection, that will include the need for hepatitis B vaccination for healthcare workers. That should be made available free of cost to the particularly for the nursing staff who are giving these injectables and all that, because we have seen huge number of these infections, those are transmitted. Then adequate facilities and training for the safe disposal of used injection equipments. So that should be in place and that should be followed in the SOP of the hospital. There are few areas which need the attention, like pediatric age group. Off-label and unlicensed use of the medicine is widespread, which may increase the risk of avoidable medication associated harms. So off-label use, that is very common in the pediatric age group. With their experience, pediatricians are going to give this medicine with the off-label indications. Then pediatric prescribing also requires weight-related dose adjustment and other dosing calculations. Over 40% of the carers who are used to give the liquid medications, those are doing some error. So while giving these medications, one should take due care. Then polypharmacy is a major problem in care homes. We in Indian culture also, now we are going to develop these care homes. This is very sad part, where we are going to have very elderly patients who are not getting the proper trained experienced staff support, where these medication errors are going to happen because they're having various comorbidities, and that will lead to the various medications. They need to take various medications, and polypharmacy will be there. So medication review by the pharmacist of such care homes, that will reduce these medication errors. So one should take care of these care homes also. So what are the solutions to these medication errors? Number of factors may contribute to these errors in primary care, including those pertinent to the healthcare professionals, patient, work environment. Work environment is also very much essential. We are very much burdened with the patient, particularly when the nurse is attending a patient. They should not be disturbed, because whenever doctor comes for the round, and that nurse has to go along with the doctor for the round, and she is unable to attend that patient, and then these errors can occur. Computerized information system should be there. Then this presents a range of opportunities for intervention. At various stages, we can intervene and we can avoid these medication errors. So key points, there are various key points that to reduce the medication error. Already I have covered this, but to summarize a few of the key points, like educating healthcare provider and patient, educating primary care provider about the common causes of medication error, then providing simple tools to assist the primary care provider in safe medication prescribing and use process. Then considering how the patient can be actively involved in medication management. So it is this, what we can say, patient, doctor, pharmacist, a nurse, they should work together for the health of the society. If we involve the patient and community in the healthcare system, then these errors can be avoided. And providing patient engagement tools to address the non-adherence. So this is very common practice because of some economic reason. This in countries like India, we don't have whatever prescription has been given, out of 5 different medication, they will take only 2 medications, or they will take medication for 2 days only. They won't take proper full course of the drug, and that will also lead to the various antibiotic resistance that we are facing nowadays, and the government also put forth one this antibiotic resistance program, that national action plan that has to be followed. Then implementing medication reviews and reconciliation that we have discussed in length. Then ensuring the pharmacist actively review the prescription. So if we don't have the medical faculty, then pharmacist at least they should take the review of the prescription, and encouraging and supporting use of medication reconciliation by clinicians, that is also essential. And using computerized systems, strengthening the electronic prescribing and alert system. So we should target the areas like injections. Then we should target children and elderly who are going to face these medication error. In implementing multi-component interventions, which will mix with the education of health professional, then health informatics, then medication reviews, involvement of community and pharmacists. Then consider specialty outpatient clinics wherever these errors are occurring, that like prescription of selected medication that require routine monitoring, like warfarin if we are giving, that patient should go to that specialty outpatient clinic where that error will not occur. Then conduct further research on medication error to develop a better understanding of causes, generate evidence for intervention impacting on adverse outcome, and to help bridge the knowledge gap in the low and middle income countries on the injection use and specialties of the pediatric population. So we have to take care of this medication error, and that will save the patient and save physician and medical fraternity also. So we have to take due care to avoid this medication error. So thank you for patient listening, because this is lunch hour and we have crossed the time. Thank you. Thank you yes, for giving me this opportunity to talk. Thank you.
Thank you very much, sir. Dr. Jain sir has given really nice presentation as a medical errors. Many aspects he has covered regarding the medical errors, and it was really a nice presentation from sir. So thank you, sir. Good afternoon. Now we are going to present one of the prescription audits to evaluate in order to minimize this medical errors, whichever has we have to actually document it at various aspects at the various level. So today, Dr. Sarvjit Khare, he is serving as an assistant professor in Department of Pharmacy. He has completed his pharmacy D from Manipal University, Karnataka, and also served as an clinical pharmacist in Wockhardt Hospital, Mumbai, and Apollo Hospital, Indore for 2 years. Also, he worked as a patient counselor in Ujjain, MP for 1 year, and also has a 7 year of teaching experience, and he has got 8 scientific papers to his credit. He will be telling us different level medical errors, how to audit it at its aspects. So over to you, sir.
Good afternoon, one and all. Myself, Dr. Sarvjit Khare. I'm Assistant Professor, Department of Pharmacy. Today, I'll be talking about the prescription audit forms to evaluate the medication errors. I'm very much thankful to the Sumandip Parivar and Sumandip University, as well as all the speakers who have spoken before me, because they have set a platform in order to evaluate the medication error, what are the minor and major complications which are being experienced by the healthcare professionals. So I'm just like an assistant to this. So for this, medication error evaluation form. There are 4 types of forms which are being designed by our department. Okay. So we have designed 4 forms in order to evaluate the medication error, and also from the different aspects like doctors, nurses, pharmacists, and any healthcare professional, as well as from the patient point of view also, because some of the observations are being already taken, also being taken when you communicate with the patient, like in patient counseling. Okay, so first I will go through the forms. Okay, so first I'll go through the forms and then I'll let you know the significance of each form. Okay, so I will tell you the significance of the forms first. In medication error evaluation form for OPD patient, we have designed it according to that. So it helps to minimize the prescription and transcription errors. It helps to minimize the dispensing errors, because in OPD patient there is a criteria. Then the patient comes to a doctor, doctor writes the prescription, and directly they go to the OPD pharmacy. Okay, so it happens like this. So that particular form decides a key role in reducing the medication error due to look-alike and sound-alike. This is a major aspect. It happens because of the legible handwriting, illegible handwriting by the doctors, and according to NABH, it should be followed in capital words. And some of the hospitals have also started using the software which are going through for the e-prescription writing, which has minimized the medication error happening through the prescription pattern. Then request the doctors to write in capitals in their prescription helps in assessing the genuinity of the prescription. Sometimes what happened, there are some drugs which are not being given without prescriptions, and the patient himself write the prescription and go to the pharmacist. Then can you please give me this particular drug? This also comes under a medication error. So if you cannot find a single aspect of the prescription, part of prescription, better not to dispense. This is a tagline for every pharmacist who is going through in terms of facing the OPD and IPD pharmacy. Next form. The significance of the next form, it is on the IPD basis. So OPD wala, it is like all the 5s are there, but for IPD, some there are, like it helps to reduce the prescription, transcription, and admission and dispensing errors. And one more thing is there, that is the documentation error, and which is being mainly done from the starting process to the discharging of a particular patient. And it also helps to reduce the unwanted side effects, allergies, IDRs, polypharmacy, or any other drug-related interactive effects which are hazardous in nature. So the third form is basically drug intervention form. It is basically being designed in order to, if you want to change a drug, if you want to give a suggestion, like clinical pharmacists are being allotted in multi-specialty hospitals. There are some resident doctors also which have the authority to change the drug, and by assessing to the senior most registered medical officer. So this particular form will help them to go for a drug intervention change. So what does it do? It plays a significant role in minimizing the drug-related problems, polypharmacy, drug interaction, suggestions, and alternative drug in place of previous one. The common most example is antibiotic therapy, because when a patient is admitted in the hospital, what happens, that antibiotic therapy should be given because there are some serious complications. So after 2 days or 3 days, they have to be changed. There should be a form which is uniformly accepted. So it also helps in minimizing the events related to interventional category. And the last form is the patient counseling form. It is a very important one, which can be used by any healthcare professional, even including the nurses, because they are the like doctors, residents, then comes the nursing part, and clinical pharmacists, and also the hospital pharmacists who are being dispensing the medicine. Because when you communicate with the patient, there are some of the important aspects you come across, which are being like the history or any kind of allergy from any kind of food items or any kind of drug. So that thing is being documented in this patient counseling, and on the whole, patient demography is being completed. So it also helps in optimizingly modifying the patient cognitive behavior and any other problem he is experiencing. And the most important aspect in the last that I have told you is, if the patient is unconscious, then patient relative is being counseled regarding his medication and lifestyle modification. So overall target of the patient safety is being achieved. So now we'll go through all the 4 forms. So this is the first form. This is regarding the medication error form relative to the OPD patient. Actually, we have designed it in such a way that you can audit the prescriptions in this. First, you can see the details of the patient, full demography of the patient. And if something is not there, you have to write there. Means like consultant name should be there, nursing staff who was attending that particular patient at the time when the error was happened. So the complete information you will get when you will audit the prescription. Okay, so in this, first important point is the demography of the patient. Second point is the allergy mentioned. Okay, and there is date of admission, date of discharge. So these 16 points will help you to evaluate the prescription for the patient who are coming in OPD basis. Okay, and in the last, you will write the type of error which you have come across. If there are combination of errors, you have to write there prescription error, transcription error, or documentation error. And in last, description of error, what the story was all about, and you have to go through the root cause analysis so that you can nullify that particular error happened in the hospital. So next form is the drug intervention document. This intervention document is related to drug intervention. Okay, if there is something going through, means a drug therapy was going through, as you can see, demography of patient and demography of patient is very much important, because for that you have to also go for the dose calculation. So it is very much important. So if there is any kind of intervention related to drug or any kind of blood or something, because blood is also being considered as a part of drug according to NABH. Okay, so you have to be very precise in writing that particular documentation. In this, if the patient is being given a particular drug, say for an example, an antipsychotic is being given, and if after 2 days the tapering of the dose should be done because it is causing some adverse effect. So you have to, you can suggest to the doctor, you can assist to the doctor, sir, this particular thing is causing adverse side effects in the patient or adverse effect in this patient. Can we go for rechallenging or dechallenging? So this particular documentation can help you for this. As you can see, the intervention identified during, these are the checkpoints where you can find this intervention, like during ward rounds, during special visits, on telephonic conversations, and patient counseling. Okay, the next one after this, intervention identified during the whole complete drug therapy, what has happened, which drug is to be tapered, is being written there. Okay, so then when you have written it, means a healthcare professional has written it, he or she can give the suggestions to the prescribing doctors or the nurses. Okay, and it should be, if you are giving information to a particular nursing, you should always keep in mind, you should always communicate that to the main prescribers, because it should not be like you can inform the nursing and they can change the dose. They are not authorized to do that. Okay, so then suggestion made to, at that moment, if you have given it to the nursing and whenever you have communicated to the physician, just tick it here. And on some physicians in hospitals are like on call, so it's better to communicate them officially on their phone or their email ID. Email ID is the best option. Okay, so these are the interventional categories which are being listed here. Okay, so after this, you can score this, and finally you can complete this particular form and submit it to the clinical pharmacist of the hospital, and that clinical pharmacist will communicate it to the medical superintendent. The next form is the patient counseling form. This is a very most important patient counseling form. Patient counseling form. So what happens in this? This is a very much effective form. In this, any of the healthcare professional who is attending the particular patient can go through this. Mainly it has been designed for a clinical pharmacist, doctors and nurses who are in touch with them. So what happens in this, again, the same profile starts with this, the complete demography of the patient, then what was the reason of counseling. The next one is the medication counseled. In OPD patient, it will be directly discharged medication, but in IPD patient, it will be the medication which is being prescribed in the IPD basis and OPD basis. Because the thing is, if you want to treat a patient for any kind of disease, you have to treat that particular patient for pharmacological and non-pharmacological. Because if these two factors come across and if these two factors surplus, the recovery rate of the patient will be more. So this particular form will help you to do this. And in this, disease information provided means you can categorize the particular disease in which he was there. Okay, and about the drug therapy means what has happened to that particular person. Okay, name and indication, precautions, dose, dosage form, frequency and administration. Means above you have seen the complete profile of the drug should be mentioned. Which formulation, what is the drug, what is the generic name, then which how much it was being given, twice daily, thrice daily, dose should be given, and if it is being revised, then the previous order should be cancelled and then it should be written again. So it comprises of this patient counseling form comprises of the pharmacological and non-pharmacological aspect of that particular patient, which will help to recover the patient on at a faster rate. Okay. So with this, I'm very much thankful to the organization, and I complete my presentation. So these particular 4 forms you can go through, and it is a very important tool in order to minimize the medication error anywhere in the hospital as well as in the clinics also. If you want to use, you can use. Thank you so much.
Good afternoon. It was really nice medical error forms which has been described by the Dr. Sarvajit, which can be used at by the physicians, by the nurses, and for the even the patient care and for the patient's information also, which we can actually tabulate, I think so, and we can use it later for our own purposes. So we are coming at the end of this today's very nice session, which has been done by Sumandi Vidyapith, that is mainly the evidence-based education cell. I would like to thank all the participants who are patiently listening to this whole webinar. I would like to even thank for JBI Adelaide University, Australia, who has supported us for this all event with the gSolution local solution area. I would like to thank even our trustees and also our Dr. Rajesh Bharani sir, our Harshal Shah, Dr. Harshal Shah sir, Chancellor, Registrar sir, Dr. Chandramani More, even the IT support, whoever helped us for this event. I would like to even to thank all the speakers, guest speakers, mainly Dr. Vikash Medi sir, Suresh Sharma sir, Aditya sir, then Dr. Jayant sir, and Sarvajit for giving us, enlightening us on most of the area of medical errors. So we will be posting you the feedback forms through the email so that we can have a proper, we can later email you, all of you, the participation certificate also by email. So within a week time, we will be sending you the participation certificates. So thank you very much, all of. So today we will be ending this session. Thank you.